It's 9 o'clock, so I think we should start. So welcome to the Manx Care Board meeting held in Ramsey. We're very pleased to be here. I hope it doesn't get too hot. It's already quite hot. We have apologies this morning from Kate Lancaster, who's one of our non-execs who unfortunately has COVID and is unable to travel. Is there anybody else, Elaine?
We have apologies from Jackie Lawless, but we have Ashley.
We have Ash with us. Thank you so much for representing Jackie. Are there any additional declarations of interest that are not recorded on our register that are pertinent to our business today? No, thank you. We have the minutes of our last meeting that was held in public, which was on the 4th of July. I will take those page by page for any issues of accuracy. So page 1, page 2, page 3, page 4, 5, 6, page 7, page 8, 9, page 10, page 11, page 12, it's a substantial meeting, so page 13, page 14, page 15. Is there anything that anyone spotted that hasn't been picked up in the action log? Nope, so we can accept those as an accurate record of our last meeting. Thank you very much. The action log has everything brought forward there until September. I don't think there's anything for us to discuss. It's all on the agenda for today, I think, Elaine, isn't it?
Yes. The first matter about the risk appetite session, that's actually had to be deferred until October.
Yeah.
But apart from that, I think everything else is covered.
Everything else is on our agenda.
I will pick up the violence and aggression policy under the people.
Excellent. Thank you very much. Thank you. Is there any other items of any other business that anybody would like to notify me of this morning? Excellent. Okay, thank you very much. Then Marina, I'm going to hand over to you. Well, you then will to take us through the report that we are in receipt of, please.
Okay. We're very fortunate this morning to have Dr. Adrian Dashfield, who is going to take us through the reports, give us first-hand knowledge and experience of it. He's the Director of Education for Manx Care. Dr. Dashfield, do you want to summarise the reports for us?
Yes, thank you very much for asking me to come. So, this is a report which is the National Junior Doctor Training Survey that happens every year. So, junior doctors are the ones we're talking about are junior doctors who are actually on a career path in training with the goal of either becoming a GP or a consultant. So these are doctors who come to the Isle of Man from Health Education England Northwest. So what happens is they're recruited by Health Education England Northwest, and then the Isle of Man is, if you like, one of the options they can go for their sort of district hospital, general hospital training. We're known as a local education provider within that setting. So our efforts, if you like, our outcomes are assessed in two ways. For this group of doctors, and we've got about 40 doctors like that in the Isle of Man. They're broadly in three groups. We've got 24 foundation doctors, 12 F1, so year one foundation doctors, 12 F2s, and they're straight out of medical school, F1, and then in their second year they become F2s. We have GP trainees, and they are post-foundation, and they're on the Isle of Man GP training scheme. Then we have this group, and they are year one internal medicine trainees whose career path is to become a consultant physician in the future. So what I'd like you to do, if you don't mind, is look at, so you've got a number of documents there. One is the GMC NTS 2023 survey. It's really just a whole stack of data there. for various different trusts. And if you can find the Isle of Man in that pack, I think it will be, I guess, on about page 2 or 3.
Page 13.
You'll see that it's colour-coded, and the way it works is that, so once a year, as I say, in May, it's compulsory for these junior doctors to complete a feedback questionnaire online. If they don't do it, then they don't progress with training. So all trainees do that, and that's one way we're assessed. And the other way we're assessed is by having a visit from health education unions to sit all the junior doctors down, ask them effectively about their experiences here, patient safety, etc., training experience. And so this is the online survey, and if you're in the right section, you'll see that there's basically data for 3 years, 2021, 2022, and 2023. And if you find the bit that says Isle of Man Healthcare Directorate, or Isle of Man Secondary Healthcare Directorate, you're in the right place. And you can see that there are various indicators like overall satisfaction, clinical supervision, out-of-hours supervision, workload, teamwork, handover, supportive environments, adequate experience, educational governance, educational supervision, local teaching, regional teaching, study leave, rota design, and facilities. And so in 2021, we actually came top in the whole of the UK, which is good. We're pleased about that. And then this year, we've come top within the Northwest. So closely followed by Liverpool Heart and Chest. That's good for various reasons, and it's a benefit, I think, to the Isle of Man population, because what it means is that we are getting junior doctors who view the Isle of Man as a good place to come for training, which means we will get high quality trainees coming here, which means we basically get better doctors, and that leads to better patient outcomes. It also means that a number of those junior doctors in future will want to come back to the Isle of Man as consultants, and we've got evidence for that. So I've been in this role for 12 years now, and we've had a policy where we've really started with undergraduates, encouraged them to come to the Isle of Man from our, if you like, feeder medical schools like Lancaster, Liverpool, Manchester. They then come back as foundation doctors, and our foundation doctor training scheme is very popular. So we're well oversubscribed. You need a score, what's known as an FPAS score, Foundation Programme Access score, of 87% to come here, which is really quite high. And that means that we're just sort of generating our own workforce, as it were. But it takes time to do that. It's a long-term policy. And those foundation doctors then, some of whom leave training for a year or two, work for us directly as what's known as F3 doctors, so they then become directly employed staff grade doctors, as it were, particularly in the emergency department. We have a lot of doctors like that. And then they go back into training at a later date, or they join our GP training scheme, Isle of Man GP training scheme. And the majority of the new GP partners on Ireland over the last 5 years are homegrown. So I guess what I'm saying is that just to view this, sort of as just a single data set is a bit simplistic. What you have to do is look at the sort of the long-term strategy, which is number one, better doctors here and now, and number two, a good place to come in future for these people who would like to come back to the Isle of Man. That's all I've got to say, I think.
Thank you. I think we're acutely aware of the need to recruit, as is every, healthcare system in the country, dare I say the world. And I think being able to be assured that our trainees are having a positive experience is incredibly encouraging. So thank you for sharing the report, and thank you for sharing your thoughts. Any questions or comments? Teresa?
Yeah. Adrian, do we have the opportunity to offer more places on the island for medical training?
We do. But there's a price tag to that. In fact, I've had a discussion with colleagues, particularly in the medical division, just last week, and we think that if we were to expand our training, we would need to aim at this group. So in other words, middle grades or junior doctors in medicine, but not ones that are quite as junior as this. So what they're on is what's known as an internal medicine training scheme, So these are the first year trainees
Yeah.
on that 3-year programme, and the other 2 years are either in Liverpool or Manchester. And what we're hoping to do, and I get with the board's consent, because it'll come down to money, of course, is that we recruit more senior doctors, like 3rd years. So they come to the Isle of Man for a year, and that would actually solve quite a big problem we have in medicine, which is to do with the medical middle grades.
Yes.
So that money, I guess, used currently on a locum spend could be spent perhaps more wisely on sort of more senior doctors in training, because I think you'll get a better quality product in general. So that would be, we think, probably the best area to expand trainees in. Foundation, not so much, because the problem with foundation trainees is that they offer relatively little service. So they have to do 4 months of general practice. They have to do, some time in psychiatry, and often those jobs are just training rather than service roles. Whereas once you get more senior doctors, junior doctors, more senior doctors in training, and they're in their 2nd and 3rd year, you get far more service. So as an organisation, I think we would benefit by having internal medicine trainees who are more senior rather than more foundation doctors.
So what you're saying is continue to support those who are purely training, so to speak, but expand in the more middle grades to assist with more service deliveries,
I'm
if I
saying
understand.
expand your training numbers to trainees who are more senior.
Yes.
So in other words, keep the first years, which
Yeah.
is what this data's about. Aim for 3rd years as well, and in return, don't employ as many locums who are doing a similar role
Yeah.
at the moment.
I think we would definitely.
I think the board would be supportive of that. Oliver and then Nigel.
Thank you. Yes, no, thank you, Dr. Sashford. This is really helpful and important. I have to say, I took that path myself. I did F1 and F2 here. I did an F3 in psychiatry here. I did my GP training here, and I liked it as a health service in an island so much that I stayed on as a GP partner here, and this is a pattern we see quite a lot. Certainly from my perspective as a GP, it's our main way of recruiting GP partners to the island is basically showing them what a wonderful place it is and giving them the chance to set down roots. And I hope maybe we can increase the number of GP trainees. I don't know if there's the scope for that.
Oh, we certainly could, and we would like to, but what we need is more GP partners becoming trainers. That's the problem. That obviously, as you know, there are strict guidelines as to how many trainees you can have per practice, how many trainers you need, to support the number of trainees you've got, and that comes again with a price tag because it's time. So, and I guess also there is a training supplement for GPs as well. But the long-term goal is to have more GP partners, which of course we really need.
I think if I could just go back. So yes, so certainly in terms of the money that practices are paid for supporting trainees, there's certainly more resource available for the more juniors, I think, rather than the GP registrar. So maybe that's something about that could be thought about.
Thank you. Nigel.
Thank you, Sarah, through you. Yeah, Adrian, thank you very much. We spend a lot of time dealing with bad news here, and this is such a good news story, and thank you for that. And I think it's absolutely key that we go forward and support it. I'm interested in the evolution of this training, in that have you observed a general upwards trend? Because arguably we are going through arguably the most difficult time we've probably seen for many, many decades, and yet the results of this training is very, very good indeed. And has that been an increase over time? Because these things don't happen by accident. Training, mentorship, the extra time that I'm sure you and colleagues put into this facility, it doesn't happen by accident. So I think it's absolutely terrific.
Oh, there are a number of factors. So first of all, when I first came here, which was in 2010, there was a mixed bag of foundation doctors who really were people who couldn't get in anywhere else. And we struggled with managing that group of doctors because a lot of them were doctors in difficulty. And also the medical students who came here were from all over Europe but not the UK. So we basically put down a couple of ground rules. That's that you had to be a UK medical student to come to the Isle of Man, because we're interested in them coming back as foundation doctors. We also, as you know, managed to raise some money to build a facility. So we've got a really state-of-the-art training facility, which is, important because one of the things that we have to do is we have to fulfil a sort of national curriculum for these doctors to come here, and obviously this feedback is based on whether they feel we've delivered that curriculum to them, and we've got to have somewhere to do that. And we've also got to have people to deliver the curriculum, and we've got to have the time within their weekly timetable to do that. So basically ring-fenced training time. So all those things we've managed to put in place over time, and the most important thing, I think, is that we've expanded our medical student base over the years. So we get 120 medical students a year now who stay anywhere between 2 weeks and 3 months. About 7 years ago, we managed to acquire some accommodation for them, which was House 7. It's quite a long story to do with funding, and I won't give you, but effectively we get a levy, which is called SIFT funding, which is supplement for training from Health Education England to have medical students placed here. That money comes in to Manx Care, if you like, via the medical education department, and that allows us to do things like, for instance, buy that accommodation, House 7, which allows us to take more medical students because there's very little accommodation around, as you know.
Yeah.
And more recently, we've actually had the Henry Boone Noble Healthcare Trust invest some of their money into a building, which is still part of their assets, but they allow us to rent this building for very little rent. Again, more student accommodation. There's another charity interested in doing the same. So what we're really doing is we're feeding the system from the bottom with medical students who then, as Oliver says, come here as foundation doctors, who then stay as GP trainees. And so I guess the success is multifactorial, but it's around income generation through having more medical students to offer a better product to the junior doctors who then might want to stay in future.
Yeah.
Without this being a cost to Manx Care.
I think it's a great story in terms of the investment in that time and future in our CCORN effectively, and the benefits that will have of not only people coming back to work here, but people talking about the place and
That's right.
talking about a good experience there.
A higher profile, basically. So one of those reports that you've got there it is a national report, and I'll just quickly get you to have a 2-minute look at that. So one of the reports is to do with the, it's called the NTS Data Analysis 2021, and it's a report by the Joint Royal College of Physicians Training Board. So basically what that is an organisation that so when you train in internal medicine and you want to be a consultant physician, you can either be under the Royal College of Physicians of Edinburgh, Glasgow or London. Now they look at all their data together, which is what this report is about. So this is all the trainees in the UK in internal medicine. And so this is a widely read report. And if you go to page 4 and page 5, you will see that page 4, they've listed the failing trusts, and at the top of that is Lincoln. And if you look at the trusts where they have the highest proportion of green flags, it's the Isle of Man. And so that puts us on the map, basically. And that's, as you say, it's people want to come here because they've read about us. And so that's the thing.
Thank you. Marina, and then Tim.
Thanks, Adrian. Just to support, it's not just coming back to be GPs. We've been successful in the emergency department in having a consultant whose first experience was as a junior trainee on the Isle of Man, and more recently a consultant psychiatrist showing an interest, and her first experience had been a trainee going through the junior doctor training program. So hopefully she may still be interested when she's ready next year. So if these doctors have a positive experience, they will join us in all our different departments, general practice, specialist medicine, surgery, psychiatry. It's a wonderful opportunity.
Yeah,
I just want to second that.
Subramanian, the care of the elderly consultant as well. He was a trainee here.
Thank you, Tim.
Thank you very much for the report, and clearly this area's been built up over the last decade, and it isn't just by chance that one gets to this stage. So thank you very much for all your work on that. I think my question is probably more a general question, maybe even for Marina as well. Looking at the narrative document at the beginning, there's always learning, and there's some really positive findings there. So two parts of the question is how does that get fed back to the relevant teams where the doctors have been placed, so that they know what they're doing is good and appreciated, and where there is learning, how does that get fed back to the teams into how that sort of continuous improvement can take place?
So we have a weekly medical education team meeting on a Wednesday afternoon, and that's representatives from undergraduate training, foundation, and IMT. So this group here. There's a college tutor, and so that's Dr. John Thomas, and then he has a deputy. All these people fulfill these roles, if you like, as a sort of add-on to their clinical practice or clinical work. And so this survey obviously gets fed back to them directly anyway, but we as a group basically sit down and sort of try and, because we're quite a small organisation, obviously it's easier to do, but we look at ways that we can improve things for all our trainees, all our trainee groups, and also the feedback, if you like, goes to the trainees themselves. So they have a weekly training session, this ring-fence time I was talking about. So foundation doctors, it would be a Thursday afternoon. This group, the internal medical trainees, it would be a Wednesday afternoon. So yes, because we're small, communication's good.
I think it's really helpful to be able to triangulate this report with other reports, so everyone gets a richer view.
Yeah, indeed. Charlie?
Just like to echo the positive sentiments of my colleagues around the table about a great piece of work. And I'm just wondering if there's a way of, if there's a way of capturing what that conversion rate is of trainees who then go on to stay
Yes.
on the island, if we have an idea.
Yep.
And secondly, just to bolster the findings and the statistics in the report, is I'm a great believer in telling stories or case studies, and I think reports like this really come to life when you hear the actual stories of people who are similar to the story that you very briefly told us, Oliver, about your journey into becoming a resident on the island. So it would be really nice, I think, to bolster the good news statistics with good news stories in reports like this, because that's what brings it to life, that experience and that journey. And for somebody like me, that's equally as important as the data and the information that's presented here today.
Well, I thought you might answer this question. I have got a list of doctors who have been, a list of names.
Yeah, it's just interesting to hear what the conversion rate
Well,
might be.
maybe,
the conversion rate.
Maybe what we could consider, Adrian, at a future board meeting is you bringing along someone who has decided to come back, or between you and Marina, have a think about how the board can understand that journey and what learnings there are for us in terms of how we encourage more of the senior trainees to come with a view then to establishing their practice here.
Well, I can tell you just what really works for the foundation doctors, and that's that we house them all together so they have peer support. And don't forget, most of them, have come straight off medical school, having gone straight to medical school from school. They've got a high level of debt, and this is the first, proper job they're doing as a doctor. and what they really need is peer support. Not just support from their elders, but actually support from people in the same boat as them.
Yeah.
And so there's been a bit of a problem in the UK, unfortunately, to do with junior doctors either self-harming or leaving medicine because of the high levels of debt and because they end up in a bed sit somewhere miles away from where they're working. They're working shifts. They often don't know the people they're working with anyway. So, and they get quite low in mood and feel quite sort of isolated. So one of our success stories is actually the setup and the fact that we've been really insistent that we do need to provide accommodation for our foundation doctors and it needs to be free.
Yeah.
Well, it's not really free because the SIFT funding that we get for undergraduates, we pay for their rent. So we pay their rent for them.
Yeah.
And that I think is really important.
Yeah.
So it's about looking after your staff actually in the end.
Yeah.
And it's about giving them, making sure that if there are relevant courses for them to go on, that we can find the money for them to go on that course. If it's a local course, it's free. So we run national courses like Advanced Life Support, Advanced Trauma Life Support. In the UK, you'd have to pay £700 to attend that. Well, if you're working for Manx Care, it's free. So it's really, as I say, about looking after your staff and appreciating them.
Yeah. Good. Well, I'm pleased to hear that we do that, and I think you have the board support to explore how we can encourage more of the senior trainees to come here. Oliver, sorry.
Thank you. I think it's so good to hear you saying about how the support that we offer to junior doctors in training. I think certainly the mood and the milieu across for junior doctors is often quite pessimistic, quite negative. And I think if we can really make a big deal out of this and really promote the Isle of Man as an answer to some of the concerns that doctors in training have across, I think that would be very, very powerful and very, very positive.
I agree. I think you could do that not just for doctors in training, but for trained doctors as well.
Yeah.
That you need to really push and when you advertise for posts, you need to really make it clearer how good the quality of life is here. That's often not appreciated.
Thank you. Well, thank you very much. Thanks for coming.
My
Thanks
pleasure.
for bringing the paper to life. And I think the board will be very interested to meet some of the trainees at a future date. Marina, if I can leave that with you.
No.
Thank you for your time, Adrian. Much appreciated.
Thank you.
Thank you, Adrian.
Marina, I'm sticking with you, I think, to introduce their staff story. You're very welcome, James, to the board.
Okay. Thank you very much, Chair. I'd like to introduce Mr. James Duff, Advanced Nurse Practitioner from Synaptic, to share with us his story. Over to you, James.
Thank you very much for having me this morning. So, as Marina said, I'm an Advanced Nurse Practitioner working with Synaptic at the moment. So a little bit about my journey. I qualified in 1997 at the age of 20. And most of my working career has been in Aberdeen. I did my training in Aberdeen, but I did have a short spell in South Wales for 6 years, which included elderly medicine, palliative care, minor injuries and rehabilitation. But the remainder of my career has been based in elective orthopaedics and trauma orthopaedics. I've now been in an advanced role for 13 years. My first advanced role was I was the specialist nurse for patients with sarcoma, so bone and muscle tumours, and for elective spinal patients. And then I went on to be the advanced nurse practitioner in the trauma orthopaedic department at Aberdeen Royal Infirmary. I did really enjoy my job in Aberdeen. But I was looking for some new challenges and some new experience, and I stumbled across Synaptic. So I've been working for Synaptic now since January of last year and first came to the Isle of Man in April of last year, using all my annual leave to come out to the Isle of Man and not have any holidays. So, as I say, I did enjoy my job at home, but unfortunately, I mean, the work at home was increasingly challenging. I worked in a 45-bedded trauma unit. Similar to a lot of the challenges you have here, we were short-staffed, underfunded. I found it more and more stressful, and I was leaving work not being happy with the quality of care, because I pride myself on the quality of care that I give my patients, and I wasn't getting that job satisfaction anymore. Unfortunately, at the beginning of this year, I had 3 friends all pass away within the space of 3 months. That kind of led me to reevaluate what I really wanted out of my life in general. And coincidentally, at that time, Synaptic contacted me and asked me if I would be interested in coming out here for potentially 6 months to help educate the Manx staff within the trauma and orthopaedic ward around the enhanced recovery process that Synaptic have currently been doing since April of last year. So my role is essentially to facilitate some education and support and oversee that transition from Synaptic undertaking the enhanced recovery care and handing it back to the staff from Nobles. I think that in the time that Synaptic have been here, I think the Synaptic team have worked very well within Nobles, and I think most of the staff from Synaptic, like myself, have come from NHS Scotland, and the challenges, as I say, that they have faced are very similar to challenges that you have here on the island. One thing that has been lovely here, we've generally all had a very warm welcome from the staff in Nobles and even members of the general public. Everybody has been very welcoming. I think at the moment the biggest challenge with the education for the staff around the enhanced recovery, it's not the actual nursing role of looking after the enhanced recovery patients is not really different from what the Manx staff are doing with their post-surgical patients, but it's more a shift of mentality, because the enhanced recovery pathway is generally a more accelerated pathway with quicker goals that still have kind of patient safety kind of at the core of what we're doing. Although it's called enhanced recovery after surgery, that's a slight misnomer, because it's not just after surgery. The process starts from initial referral with GPs. Obviously, the patients come in and go through their pre-assessment. They have any kind of pre-existing medical conditions assessed and hopefully optimised prior to surgery. We admit the patients on the day of surgery, and ideally most of the patients will normally have a spinal anaesthetic and some light sedation, which means that when they come back to the ward after their operation, they're awake. We can start them eating and drinking straight away. As soon as the spinal anaesthetic wears off, we get the patients up and mobilise them, which can be anything from, just before the end of the last phase, we had one lady that came back after a knee replacement, and she was up and walking to the bathroom within an hour of being back on the ward. The standard, we try and use a standard analgesia protocol so that everybody is kind of following the same pathway. I'm in the process of setting up a steering group with all of the heads of department, from physios, OTs, consultants, anaesthetics, because obviously Synaptic have their enhanced recovery pathway, but I want to make sure that for Manx Care we have a Manx Care specific pathway that meets the needs of Manx Care. So we'll sit down and look at that and kind of tailor the pathway for that. The way that I'm kind of approaching things, for this phase, we've just restarted this phase of operating. So what we're now doing is we're essentially doing a blended approach. So some of the staff from Ward 11 will come through to Ward 12, and I'm then relocating some of the Synaptic staff to Ward 11 to cover, so that the Manx staff are actually looking after the enhanced recovery patients, because the last phase they were coming through for shadowed education, but really just watching somebody do the care is not really the best way of learning. So I'm hopeful that over this 4-week period we should be able to get a lot of the Manx staff educated and feel confident around the enhanced recovery process, and then moving on to the next phase, my plan would be that we go to synaptic covering night shift and then the Manx staff covering day shift. And then after that 4 weeks, if everybody is feeling confident with the enhanced recovery process, then synaptic may be able to step back. So we're kind of possibly looking at that maybe taking place in November, possibly the beginning of December. I would like to think that synaptic during the time here have not only benefited the patients that have undergone surgery and things, I think it's provided benefit to the community at large. Obviously, the longer patients are waiting for their surgeries, the more difficult their recovery process is, so I think it would have benefit with the community. I think there is a very good opportunity within Manx Care, because I think once Manx Care take over the enhanced recovery process, with a lot of the waiting lists being reduced with synaptic doing some of the surgeries, I think there's the opportunity to go back to offering private work for hips and knees. If you've got a well-established enhanced recovery pathway, that will lend itself to then providing some private work as well. I think also I would kind of echo what Adrian Dashfield had said with regards to recruitment for nursing staff. I think within Manx Care you have a very unique opportunity in looking at recruiting nursing staff, advertising the lifestyle here and the support and the education and things, I think would make it more attractive to nursing staff from NHS Scotland or England if they wanted to come over. And I think also even things like the fact that you have the racing, that also is an attraction if people have an interest in trauma nursing. I think that would benefit and actually perhaps bring in more interest for nursing posts. And I think I've probably waffled on long enough.
Oh, thank you, James. Thank you very much indeed. Does anybody have any questions or comments? Katie?
So, funny enough, I was going to ask the same question to Adrian about how we can use the learnings from the doctor programme to develop. So I'm glad you said that, but loads of people asked questions, so I didn't. But I was actually thinking that.
Yeah.
So I think that'd be really good, because obviously there are more disciplines than just doctors that we need to attract to the island. So I think that's a very good idea. And the other thing to say is that we noticed a huge difference, and Oliver's been very diligent about showing us the impact that the synaptic work has been having on the backlog. And it's breathtaking. It's absolutely breathtaking. So thank you for being part of that.
That's all right. And I've actually, as well as I should have also said, I'm currently, for setting up the enhanced recovery process, I'm just in the process of completing audit paperwork to go to the audit board so that I can have an audit sheet in place so that we can audit the enhanced recovery process as we're kind of transitioning from synaptic to Manx Care, so that we can then gather data, look at how the enhanced recovery programme is working, because the thing with an enhanced recovery programme is it will naturally develop. We might start off with one pathway that has a suggested anaesthetic process, analgesia process, but as you kind of go through and you maybe get your audit data and patient feedback, things may need to be adjusted and tweaked. So the idea is that we will then be able to have the audit data to back that up and demonstrate where we have made improvements and where things have worked well and things haven't worked so well, and then you can adjust it from there.
Brilliant. That'd be a really great learning opportunity.
Teresa and then Nigel.
Yeah, I guess I only just wanted to, reflect on that evolving relationship with synaptic, and I still think it was quite a strong leap of faith by the Manx Care Board to bring an external provider in to come and assist us with the waiting list reduction, recognising that it was going to take us an awful lot longer to reduce the waiting lists following COVID if we were trying to do that on our own. And again, we made that commitment that if we were bringing Synaptic in, we were going to make sure this was an opportunity for our own staff and to leave behind all of those enhanced pathways. And we've heard at the board previously about the impact on length of stay from sort of 4 or 5 days to 1.4, which clearly means we're able to operate more efficiently, get better outcomes for our patients. So I do just want to reflect on that. And I think coming back to what Adrian said about medical training and what you've also said about the lifestyle and the opportunity here, and that sort of comment as I'm able to do my job really well to a high standard here. I always lead the induction of new starters to the organisation, and I led the induction last week, and there was 36 new people, and the clinical staff particularly were saying the very same thing. These people are probably only 3 or 4 weeks into their career with Manx Care, so but in their induction they're all highlighting that Manx Care is giving them the opportunity to work to a really high standard, but in a very supportive environment. And I do think that is something which fits with our cultural improvement, and something we must try and find a way to share that with our recruitment processes, because we are consistently hearing that message from people who come to join us here on the island, both the lifestyle improvements, but what the job can offer as an integrated health and care organisation.
I mean,
so
I think even from the kind of the workforce point of view, I mean, obviously, I can only really reflect on my experience in Aberdeen, but as I said, kind of a 45-bedded trauma unit. Now, our average staffing level for 45 beds was between 6 and 8 trained nurses, and then for medical cover there was myself and 2 FY1s for 45 patients, which is just you can't provide the quality of care with those sorts of, but over here I find that you're able to provide that more quality care because you actually have more support, and it just makes the job easier and more enjoyable.
It's really good to hear.
Thank you. Thanks, James. Nigel.
Thank you. Really enjoyed your story, James. Thank you for that. And it's a sort of supplementary to Teresa's question, really. But I'm interested in your perceptions about culture in the organisation, because we sometimes get mixed messages. And, you know, we've had this delightful story from yourself this morning, delightful story from Adrian about success stories. But often, you know, it's a source of great anguish to me personally that we spend far too much time talking about money in a care environment. But money is one crude way in which we reward ourselves. It's not the only way. And it's great to hear you talking about excellence of service, job satisfaction, improvements across the piece. I think it's really heartening. And I think it's something that we should be singing from the rooftops.
Yeah.
But I'm also interested, we received a very early doors presentation from the clinical lead in orthopaedics and one of the synaptic surgeons. And they said that actually the relationship had worked very well, when in fact that was sort of counterintuitive, as we were wondering whether it would work well. Bunch of outsiders coming to the Isle of Man, telling us how to do stuff, you know. And I'm just interested in your perception of the reality rather than the rhetoric of the cultural exchanges that you've seen and witnessed in your work in the organisation.
I think certainly in my experience in the time that I've been here, I think initially there has been some reticence and resistance to Synaptic as a team coming from outside.
Across.
Yes, but I think that was very short-lived. It didn't really, it was on kind of, I mean, even when I came over here, there was a comment made to me of, oh, you're the person that's here to teach me how to do my job. And it was like, well, when I explained to them, well, actually, no, because what you have been doing with your elective orthopaedic patients is vastly different to what we're doing in the mentality. So I'm not here to teach you your job, I'm just here to teach you a different way of doing your job. And once you explain it to them, that resistance went quite quickly. And I think I've settled in quite well, and there's not been much resistance after that. I think once you're able to demonstrate that you're providing quality care, safe care, and that the patients are satisfied and getting good outcomes from things, then that kind of eases off. I think it's, as they say, the proof is in the pudding.
And I think it was important for us to hear you talk about embedding the learning in the team.
Yeah.
Because I think part of that reticence, perhaps, Nigel, came from a fear that you were going to come in and do something and then go away and it would go with you.
Yes.
And I think one of the things that we've really appreciated as a board is hearing from your colleagues and then very clearly from you today that actually, ensuring that learning and those enhanced pathways remain is really important for us, because as Teresa said, it was a risk that the board took, and it's been really brilliant to hear the improvements for patients, obviously, but also the improvements for staff, and that increase in job satisfaction is not something that we take lightly. No. So thank you so much for coming today, sharing some of your own story as well as some of the work you've done here. It's really, really appreciated. Thank you very much indeed.
Thank you very much.
Thank you.
Thank you so much.
Right, we're coming to you, Paul, if we may, for the board assurance framework.
Thank you ever so much, Chair. Thank you for inviting me to do a deep dive into the assurances upon which the board rely on quality and safety. I managed to stop myself from descending to the depths of the Mariana Trench, you'll be pleased to know, but I have gone into some detail and I hope I'll do this justice. The risk that we're dealing with is a complex one. It's framed in such a way that it sounds so simple, but actually it's multidimensional and interdependent. And I outline here for your benefit a number of dimensions that are taken into consideration when we're looking at the risk to the safety of care. And I've set out some positive and negative assurances, and they're both of equal importance to the board. I've never known or never worked in a situation in running a healthcare enterprise where everything is perfect. It's just not something I've had the luxury of experiencing. And the reality is the same here in the Isle of Man. So I'm going to summarise, if I can, some of the highlights that are positive. And these largely reflect a lot of the work that we've been doing over the last couple of years since we started working at Manx Care. So one of the first things I encountered when I got here was an absence of assurance on recognising and responding to the signs of clinical deterioration. And that was in stark contrast to what I was used to working with in England. And when we started to explore it, we found that actually our assurances were incredibly low. We weren't able to demonstrate that we were monitoring the vital signs at the right times, and that where we found the vital signs to indicate a need to intervene, we weren't escalating in the right way or in the right time scale. And it wasn't always obvious whether there had been a response to that escalation. And so we did a piece of work on this. We set up a task and finish group. We worked really, really hard. It was a slow burn to begin with. It took quite a lot of effort on our part to get the standards in place and to drive compliance. But, it's one of our success stories. We have managed to achieve much higher reliability in the measurement of vital signs. We've engineered within our software called Patient Track the auto calculation and the auto escalation and elevation of people who are requiring review. And we're much better at reviewing those patients when we escalate them. So that's a real success story. But in addition to that, as a spin-off from that, it's also allowed us to focus more directly on making sure patients, when they arrive in hospital, have treatment escalation plans in place and considered, so that we're anticipating deterioration before it happens, and we're working on a clinical plan as to how we might respond to prevent that from happening, or if it did, what we would do. So I think the assurance on that is pretty good, and we've stood down the task and finish group, which was our mechanism for making the change there, to allow us to focus on other important projects, like, for example, discharge letters, which is something that we're working on at the moment. And similar to that, the malnutrition and universal screening tool, it might surprise some people, particularly those listening to the meeting today, that the risk of malnutrition and dehydration in hospitals is actually surprisingly high. There are all sorts of reasons for that, which I won't go into today. But the reason why we have the universal screening tool is so that we can identify those people who are at risk and make sure that we have the wraparound support and care and the right intervention so that we minimise the risk of dehydration, which in turn minimises the risk of delirium and some of the dependency that we find in hospitals, and make sure people are properly nourished and have the right kind of meals. Now, our assurance on this when we started was, well, it was unrecordable. We didn't really know where we stood. But now we've got to a point, this was another slow burn. It took a while to embed the standards, get the drumbeat going, hold people to account, and then resolve the problems that they were experiencing. It took about a year. But in the, as you can see from the graph that we're showing here, we have made very steady progress to the point that we're now at a point where we would consider this transitioning from a problem into high reliability care. And we're doing similar work with patient falls. Now, I point out that falls are inherent risk for healthcare providers. As I highlight here, all kinds of things combine to increase the risk. So the ageing population, the frailty amongst that group, polypharmacy, which stands for lots of different types of medications that people take nowadays, drug and alcohol use and care dependency combine to increase that risk. And there's not a lot I can physically do about those risk factors. So therefore the risk of falls is inherently high. But we focus on the management of that risk so that we minimise the potential. And I give in the analysis here that our exposure to falls is on a par with what you would see in NHS England. It's around 6.5 per 1,000 occupied bed days. And in England, around a third of those result in falls that we would classify as harmful falls. But on the Isle of Man, our exposure to harmful falls is much lower than that, which indicates that the work we're doing around managing medicines optimisation, medicines reconciliation, the right kind of decluttering, the right kind of anti-slip footwear, the use of walking aids, and support from staffing is making a difference in a positive way for people who are receiving care here on the island. I make reference here to exposure to serious incidents, only to illustrate that, like everywhere, we do experience serious incidents on the Isle of Man. We have put in place frameworks which everyone around this table is very familiar with as to how we manage them. And I think it's fair to say we have manifestly shifted our culture and ability to talk about these things and learn from them in ways that are less stressful and less combative, so that we're putting ourselves into the shoes of the people who've experienced the harm to understand what we could do better and learn from that. And we have seen a slight decline in the number of serious incidents that we have had since Manx Care was established, but we've by no means eliminated it. But we are able to demonstrate good assurance that we're learning from these things. And over and above what many of my counterparts in England will do, we introduced causal factor analysis as a tool for getting underneath the real issues, what's genuinely going on that's driving serious incidents. And chief among those issues is, would not be a surprise, is communication, the task in hand, how complicated it was, whether you had the right stuff, patient factors, how sick they are at the time, or how many comorbidities were they dealing with, what's the working environment like. We know against all of those we've got some challenges. And it's identified a number of areas that we need to continue to work on as part of our safety management programme, like, for example, how we gain access to policies and procedures and simplify those documents. We have something in the region of 2,000 documents that you might say would govern or does govern the way care is provided inside Manx Care. But if you study human factors, you will very quickly realise that most people can't remember more than 7. We've got 2,000 that we would expect people to follow and hold them to account for following. And when you think about that requirement, it changes how we view the world in governance. How do we give people access to these documents in a way that enables them to do the right thing from the very beginning, as opposed to consult the documents when something's happened to figure out how we rescue the situation? And this is a big challenge for all healthcare providers. And eventually it will wean us away from pieces of paper as a means of governing how we do business and programming into the software solutions and the IT systems the standards and the requirements so that we engineer the human error potential out of that process as far as we are able to do so, whilst retaining the clinical knowledge and skills needed to interpret the changes subtly. So we're doing a lot of work on that. And whilst I can't give you assurance that we have no serious incidents, I don't think I will ever be able to do that. I can give you assurance that we are working very hard. We are aware of them, we investigate them, we change, we learn, and we adapt, which I think are very important. Similarly with complaints, we've done a huge amount of work on addressing complaints. Complaints was a challenge when I first got here. We had a backlog of historical complaints, and those complaints themselves went back a long way. So it felt like I was going back to my youth. In fact, some of the complaints we were dealing with originated from a time when Margaret Thatcher was Prime Minister. Such was the timescale that we were working with. We have managed to resolve all of those historical legacy complaints. In addition to that, we have speeded up quite dramatically our responsiveness to when people complain about our services. We're much more open and willing to learn from the issues that people flag, and we assign much greater priority to the views of those who've experienced our care over and above those who deliver it. And that's helped us to really get underneath some of the issues that people have. And when we do that, they're simple things. More often than not, they're very simple things. And it tends to be about communication, so knowing where to go. It's about access, not making people wait. It's about access to the service in the easiest way possible so they can get here and get home again and they're not hanging around. It's little things like that that make the big difference. And as I illustrate in the MCAL's paragraph, that's exactly what we're doing. It's my view that most of the issues that people experience that are problematic for service users, if they're identified, can be resolved there and then on the spot. And in 90% of cases, that's exactly what we're doing when issues are raised with MCALs. Now, that's a tremendous success. There are very few organisations that I know are able to demonstrate that level of assurance to the board. But we are able to do that here in Manx Care, which I think it shows our complete commitment to the end user service experience being one of the most important outcome measures that we use in Manx Care. And because of that drive and determination, we are determined to resolve those issues as fast as possible. And whilst 90% are done on the day, 97% are done within a week. And I think that's tremendous. And it does have an impact on reducing the number of complaints that come into the system. That in turn reduces the burden, the bureaucratic burden that's required to process those complaints. And I'm quite sure it reduces the anxiety for people who have got an issue with Manx Care because we're able to address it more directly. There are some other things which I will touch on very briefly just to summarise. We have simplified and rationalised quite considerably the range of patient group directions available, and these are prescriptions that are put in place for people that you've not yet met, and they're for a whole raft of things. It's an easy way and simple way of administering medicines when you don't necessarily have a doctor or you don't have a prescriber. But the volume of these documents was overwhelming. I mean, just imagine the audit burden and the governance burden associated with 800. We've done a lot of work to simplify, rationalise and reduce, and we've taken the volume down from 800 to 172. So those are the most important prescriptions that require to be done in advance as part of a patient group directive. It makes it easier for me to manage that formulary, and it makes it easier for me to ensure that those practitioners engaging with those procedures are knowledgeable, equipped and qualified to do so. But more importantly, what it allows us to do is to exploit the opportunity that exists to enable practitioners like James and others to practice right at the top of their game and exploit their non-medical prescribing rights and privileges. And that allows us to move away from a dependency on PGDs into enabling practitioners to work right at the top of their game, and that will be a magnet also for encouraging people to come and work on the Isle of Man, because they do want more autonomy, they do want more freedom. We've done a huge amount of work on risk, as you know. We're not quite home and dry on risk, but you know that we've been able to embed a new process. We've got a good framework in place. We have a challenging risk committee, which is chaired by the chief exec, to scrutinise and examine not just the risk itself and the estimate of exposure, but also what are we doing to manage that? How good are we at dealing with that risk? Where could we take that down? So there's rigorous challenge and review going in. All our care groups have rebuilt their risk registers from base in this last 12 months, and that's made a big difference to our risk awareness and risk insight and what we're able to tolerate and not tolerate. And in that regard, we've held 2 sessions with our senior leadership team on understanding and developing the risk appetite. And it's obviously that's clearly a board decision, and we've got plans to conclude that process in the autumn once the appointments to the board have been confirmed, and then we'll be able to clarify what the appetite for taking risk is. And when we're clear about that, the advantage of that is that it sets the boundaries for our operational teams and our clinical leaders, so the limits beyond which they're not authorised to take risk without the board's consent, and that stops things from happening by surprise. And then finally, I talk about, in positive terms, I talk about the workforce, but I use the safer nursing care staffing tools as an illustration. We did a huge amount of work in the last couple of years on understanding what our staffing needs actually are based on detailed acuity and dependency analysis across all the areas. And those reviews were very detailed indeed, and they led to a complete rewrite of our workforce models, which has allowed our workforce models to be properly costed and budgeted, and we use the information now as part of the health roster system to evaluate something called fill rates, which is the number of hours planned and the number of hours that we're able to fill. And that gives us a proxy measure for whether staffing is safe. And as you know from the conversations we've had, the board has been generous, and so has the Department of Health, in allocating funding for the international recruitment campaign and the programme that we've put in place to double the number of trainee nurses on the Isle of Man in mental health and in adult nursing, and increase the bursary, all as a combination to boost our pipeline of nurses for the future. I've used the phrase before, growing our own heroes. And whilst James talks about the Isle of Man being attractive to international recruits from England and elsewhere, that I think is true. But our turnover of many of those colleagues is a year or less. And so people who are born and bred and grow up and learn on the island are much more likely to put down roots and stay here for longer. So that's a programme that I think we can take positive assurance. And we have substantially stabilised our staffing challenges. Turning to some of the assurances that are not so positive, I stay with staffing for a moment because our work is not done, not by any means. Whilst we have done a huge amount of work to set the foundations, the number of people who are retiring, the number of people who are leaving, the amount of vacancies that we cover, the increasing acuity and dependency, they all combine to create pressure on the service. And we do experience some problems in some of our areas, and that leads to some of our areas being particularly vulnerable, and I'm going to mention a few which have been no surprise to the board. Areas where we are dependent to a large extent on temporary workforce, and that whilst our recruitment programme has substantially avoided the need for temporary workers in our Band 5 core general roles, we haven't been as successful in some of our more senior and specialist roles, and that meant we've got some vulnerabilities in maternity and children's ward, but also in some of our allied health professional areas like paramedics, physiotherapists, speech and language therapists, as well as doctors. And so our work is not done on stabilising and shoring up staffing. And as a growing concern, we are seeing increasing gaps in healthcare support workers, and this I am worried about because it would appear that it is not an attractive option for people who are resident on the Isle of Man to take up a role as a healthcare support worker in Manx care. And actually that's not surprising, because compared to England and elsewhere, we generally speaking don't pay the same level of pay for our healthcare support workers. We on the whole pay a band 2, whereas in England you can expect to receive a band 3 if you've had special training. And I think that is causing a problem for Manx care now, in that it's not an attractive prospect for many people who can gain better paid employment on the island in other sectors, and it's something that I think we should look at. In the table 1 that I give you for information and detail, this is a fill rate table for June, and we use this to gain assurance on the adequacy of staffing levels. And essentially the way it works is you've got planned hours, which is what the rota says you need, and the actual hours, which is what we have delivered to that ward. And you end up with a percentage for the day and the night. And whilst I'd like to say 100% would be the standard, and I think it would be the gold standard, I'm happy to accept a standard of 85% or more of actual hours against the plan as being adequate and safe. But you can see in the areas that I've highlighted here that we are not able to achieve that, and in many cases our fill rate drops well below the 85% requirement, which would give the strong indication that we struggle to maintain safe staffing levels in those areas at times. And that leads to a whole load of countermeasures and procedures that we have to put in place operationally, day by day, sometimes several times a day, to move people around. This causes great angst amongst my colleagues in nursing when they are trained to work in a particular area, but we're asking them to go and work in a different clinical area. It causes a great deal of stress and concern and anxiety that they may be operating outside their field of expertise and skill set and working in an environment that they're not familiar with, and the risks intensify. And we work through those challenges day by day, but they continue, which is an indication to me that we haven't quite got the level of safety that we need. I mentioned in this paper in some detail, which I don't intend to go through now, the infection prevention challenge that we're seeing. COVID was a massive infection prevention challenge for almost all healthcare providers. And as we move out of COVID, we're witnessing a phenomena that we can't quite explain scientifically, not yet at least, but we're witnessing phenomena where we're seeing a fourfold increase in Clostridioides difficile infection, which is an infective diarrhea. And it's often linked to a number of risk factors like age and the use of certain types of drugs. And I've given an indication there, the kind of drugs that increase the risk. And chief among those is antibiotics and something called proton pump inhibitors, which are medicines that people take to control gastric reflux and acid. And we've had a fourfold increase in this year, 2023, for Clostridioides infections. And in response to that, we've done a very rigorous review of our infection control procedures and our practices. And whilst in many of those areas we are doing very well, our investigations haven't identified anything material, we have experienced some challenges that we will need to address as a board. And they're things that I would say are treatable. And they would relate primarily to the condition of what we call the bedside furniture. And this would be the chairs that patients sit on, the stools that they would use to raise their legs, the tables that they would eat their dinners off, and the lockers that would sit beside the bed. Where those devices have been checked, some of them have been found to be defective. So the veneer on the wooden lockers, for instance, has lifted because moisture's got in. And you can safely assume that they will be contaminated from that point, and you cannot decontaminate them. The same would apply for chairs that have a rip and the foam is exposed, or the mattress is exposed. Those are things that we're doing a stock take now, that we will need to replace and replenish those pieces of furniture to make sure we're absolutely tip-top. And there's work that we still want to do on increasing the reliability and performance around antimicrobial stewardship, so that we can make sure that where we're using antibiotics, we're using them appropriately and there are no other options open to us, but that we're reviewing the use of those antibiotics quickly and making the right decisions when to stop, when to start, or when to change them. I mentioned mandatory training here in part because it is so damn difficult to get some progress on this issue. We've got a mandatory training system that is incredibly complicated. The sheer volume of subjects which are categorised as mandatory is overwhelming. The number of hours that are required for people to complete that training is out of proportion from anything you would experience anywhere else. And I think it's laziness, really, in that people are just classifying something that's important and necessary as mandatory, and therefore adding the burden. And so I did some training in my place, like I mentioned to Teresa, I did 40 hours of mandatory training last year. When I came back to review it a year later, even though I did another 40 hours, there was 160 hours that was there to be done on top. I need to take out about 1.5 months of my entire year just to be able to deliver or do mandatory training. That's just not doable. It's not doable when you're short of staff. It's not doable when you've got other priorities. So we do have to simplify and rationalise, and we have to be quite radical in that. Because what we end up with has to be a core set of subjects that apply to every single person employed by Manx Care. And that core set needs to be simple and easy to achieve within the shortest possible period of time so that we can get those people onto the same page. Then over and above that, there will be training that's relevant to the role that you do. And that's the bit that would be role specific and would need to be done and achieved over a longer period of time. But we've got some work to do on that. We also want to participate more in what's known as the National Clinical Audit Programmes. We have made some good progress on this, and we take part in some of them, don't we, Marina? But we want to participate in more because they will give us really strong clinical benchmark evidence as to how we compare with similar sized providers in a similar context so that we can genuinely evaluate whether the standard of practice and outcomes are good or not. And we want to participate more in that. I've mentioned already about the vulnerable services. Industrial action does pose a risk to the quality of care. I think it'd be wrong of me not to acknowledge that here. Whilst every effort goes into making sure that the standard of care is maintained as far as reasonably practicable during industrial action, it nonetheless poses a risk, particularly those whose care is delayed or postponed as a consequence of the action that's taken. So it does represent a threat. And then finally, just to acknowledge the work on safeguarding. Safeguarding is a huge undertaking across the Isle of Man. The Safeguarding Board are doing a lot of work on this, bringing together all the agencies. But we have to align our policies and procedures and educate and train people, and the amount of work that we have to do still remains to be quite significant. Although that work is progressing, it's still quite a long way to go. So in terms of explaining the reason why we are holding the risk at 15 is for those reasons. We have some good assurance that we're doing the right things and we're making progress, but we have some vulnerabilities that mean the probability of unsafe care, perhaps at a level that one might consider to be serious harm or death, the possibility of that is still there because of the various challenges that we face across the organisation, and for that reason we keep the risk at 15 at the moment. And Chair, if I can, I'll pause there for questions.
Thank you. Nigel.
Thank you, Sarah. Paul, thank you very much. As ever, an amazing detailed paper, celebrating some great things and being very realistic about some others. It would be no secret to colleagues in this board that we are entering a period of tension and stress in terms of our approach to the cost base and in terms of balancing the need to our stakeholders and managing our finances effectively. It's very clear as well that recruitment and retention, where you look at figures where you're below your 85% tolerance level in terms of your staffing rotas, that poses a risk. How do you see the landscape for managing risk going forward in an environment whereby if we can't recruit and retain, and we are operating at a lower level than we would like to operate, therefore we're spending more in cost terms on bringing people in to plug those gaps and also mitigating those risks and dealing with those risks. It's exacerbating the problem, isn't it? So how do you see the landscape for managing risk going forward?
I think that's a really good question, and I'd like to answer it with a kind of eye on the future as to how I think as a board we might tackle this. I don't see a difference between high quality care and the best financial stewardship that we could provide as a board. There is an awful lot of evidence that high quality care costs less. And the sooner we can intervene, the better the outcome for the patient, the higher the experience of that care, and the less cost. If we do the opposite of that, if, say, for example, we delay care, we make people wait, they will deteriorate. Their conditions don't remain static. They continue to evolve. So we will find more people with cancers that are untreatable at the point at which we see them. We'll find more people who need knee and hip operations in suffering for longer with great pain, and by the time they come to have their surgery, their chances of recovery will be diminished considerably. And we'll see people, there's a concept called deconditioning, which is well known in my field as that general deterioration of patients' independence and ability to cope and function in a normal independent life. And if you've studied deconditioning, you'll know that it's rapid. It happens so quickly. And so, and that's where your costs come in. That's where your costs really ramp up. Is if we don't get hold of the care need at the first and earliest opportunity, the cost of providing that care in the long run is perhaps overwhelming. And the experience of caring for people in that situation, staff find that very difficult. They want to do the very best for the people, optimise their health outcomes, return them to full tax-paying status where possible, as soon as possible. They'd much rather enable and support people to do that than have to deal with the consequences of delaying care. So I'd like to think that as a board, we will take heed of the evidence that high quality care costs less and invest in doing the right thing at the first opportunity for people so that we can get it right first time.
Thank you.
Thank you.
Teresa.
Yeah, no, thank you, Paul. I think just reflecting the level of data, detail, assurance we're able to give is really positive. When we met with the Royal College of Nursing a few weeks ago, the ability to be able to have Band 3 and Band 4 nurses in our organisation was very apparent. It enables them to sort of have a increased skill set, be able to prepare for a registered nurse career and training if they wish. And it also helps them to live on the island because the cost of living is very high. And I think, I heard that loud and clear, and I would agree. It's very unusual for an organisation to have such difficulty filling unregistered shifts, so healthcare assistant shifts, and I think that is a unique problem for us, and we must start to look at how we can accelerate the pay bands and bring in the associate nurse, which does need some regulation changes, so it is one to discuss with the Department of Health and Social Care. The mandatory training is irritating that we have made so little progress, and I think we must escalate this one and look concertedly at how we address this. For me, this should be something within the gift of the Manx Care Board to agree what are the core mandatory training requirements that we have across the organisation and take the decision to do that. I hear it time and time again in the induction, just how onerous, just how much training and how unrelevant a lot of staff feel it genuinely is. So it's not added value. And I do think we must escalate this matter, particularly out of Paul's assurance report, and specifically task a group away from the board to bring something back, which is a concerted profile of what training we do feel is appropriate across the organisation quite quickly. It's lingered for too long, in my opinion.
So, Teresa, perhaps that could go into the operational group and then report into the People Committee, and then come back to the board. Because I think it's something that we've discussed at People Committee again and again and again, and it was the one thing in Paul's report in terms of issues of concern that really leapt out at me. We have to be in a position as a board where we know that our staff are adequately trained, and if we can't get that from the system we've got, then we need to change that. Marina.
I just wanted to congratulate Paul on a very detailed and appropriate report, and he's highlighted very important changes that need to take place, and second Teresa's view about the mandatory training that we have to look at this, but also, most importantly, taking on board the feedback that we got from Adrian this morning. If we're going to be training doctors and other professions, we need to invest in high quality care, because that's what good training organisations do. And in the long run, it will cost less, even though it may cost more initially. I just want to put that forward. Thank you.
Thank you. And Paul, thank you for such a detailed report. I was reflecting with colleagues last week that, when I first joined the board, I used to ring Andrew and say, did I miss the bit where the data was discussed about? And Andrew would say, no, we don't have that, Sarah. And so to be in a position where we now have such detailed information and we can take, assurances, but also similarly, we're able to understand where we can't take assurance is really important. So thank you so much for all of that work. It's much appreciated. I'm sorry that my chair's report is in draft form. I don't quite know why that's ended up in the pack, but it was Dr. Phil Banfield who came from the BMA, and I'm sorry that his name is not in my report. I have some additional comments to make when we get to our finance item, but I'm willing to take any questions that people may have about my report. Teresa, on to yours.
Thank you, Chair. So as ever, my Chief Exec report is supplemented by a detailed horizon scan, which evidences a lot of the work that's going on within our operational and corporate teams. And I do want to just pull out a few of those for mention today. I think it's really positive that within the Integrated Cancer and Diagnostics Service, we are seeing some really positive recruitment. So consultant radiologists, we have made 2 offers. We have recently appointed a Band 7 sonographer and a Band 7 mammographer. So really important appointments for that directorate. Some really positive news in that we have been working for some time on a very detailed business case to increase capacity within the CAMS service to be able to implement the Thrive model, which this board has endorsed. So that business case has been completed. It had been through Treasury before with some comments and feedback. It has now been resubmitted. So we really hope that business case is successful. It really will allow us to accelerate the implementation of Thrive, whilst also adding some very well-needed capacity into the service. I also wanted just to flag that the theatres and aesthetics team, as the board will be aware, we achieved the Association of Perioperative Practice accreditation last September, so just under a year ago, which was the culmination of 18 months hard work to look at all of the quality standards within our theatre complex. We are just about to invite a peer review, so a peer review of how we're doing is being undertaken in September. We talked at the last public board around the positive approval of some new initiatives which will really support our urgent and emergency care pathway. So we have had some funding approved for same-day emergency care, which allows us to treat people in the same day, accelerate their pathway and diagnostics in order to prevent an admission to hospital. We have got funding for see, treat and leave in the ambulance service, which again will allow people to remain at home with an agreed care package or treatment plan. And also hear and treat, which again is clinical navigation in the joint control room. Again, all helping us to keep people in their own homes or in their own environment where at all possible, and not to convey them to hospital if that's not necessary, and also intermediate care. There is the government conference on the 21st and 22nd of September, and that will give Manx Care a further opportunity to share some of the detail of these new clinical models with the public as we implement them. I would also just like to flag that the multi-agency safeguarding hub, which launched at the end of June, is going really well, and also the Edge of Care pilot, which we have talked about at the board, is achieving some great outcomes for the young people involved in that service. Within our family, women's and children's services, we continue to work on the integrated sexual health model, and there's some really good work around linking in with various audits and networks and being able to assure our services are of the highest standard. There is the consultation which went live at the end of last week around women's services. So this is a broad consultation, really looking at access to services, the type of services we offer, where we offer them, and trying to create a cohesive strategy for women's health going forward. And that's been done in conjunction with the Department of Health and Social Care. Like your report, Chair, I just wanted to acknowledge the efforts of all Manx Care staff in responding to the TT and also the Manx Grand Prix, which has just finished. It was an incredibly busy month for all of Manx Care services, and it's sort of, I think it's really important we acknowledge that it's not just the teams who are dealing directly with the trauma and the care. It's the community nurses who have to alter their schedule of visits, and everybody has to adapt and change in order to support racing. It was particularly tricky as our racing schedule also coincided with strikes of consultant medical staff in the UK in the lead up to the bank holiday. I've also included in my report some details about the Regent's Dental Service. Regent's Healthcare have handed back their contract to us. It does affect 6,500 patients, so it is quite a high number of the registered practice, and they hand that contract back at the end of November. We are currently in active discussions with the Department of Health and Social Care about how we resolve that. There are a number of options as to how we would resolve that, but we are looking to increase our emergency dental service in order to try and mitigate the impact of that. I would just like to acknowledge that the final version of our Ofsted report has been received, and there is a comprehensive action plan in place which has been developed by the service. A number of those actions have already been completed, and the report and action plan will be published towards the end of October in conjunction with the Department of Health and Social Care. I just want to also touch on Cummel Moor Care Home. There has been a lot of publicity and interest in this matter for obvious reasons. In conjunction with the Department of Health and Social Care, Manx Care have taken the decision to put on hold any plans to close Cummel Moor. This is whilst we understand the position more fully around the proposed redevelopment of an alternative facility to Cummel Moor and the availability of capital funding from Treasury to do that. Obviously, we had been honest with our staff about the position and the delays with achieving capital approval. We have now had meetings with staff members, residents of Cummel Moor and their families to give them the assurance that over the pause, and we will, and I've committed to keep them updated as we understand more. It is really important that we understand from a Manx Care perspective how long it will be before we have a replacement facility and what the timelines and process looks like for securing that funding. As I say, the replacement of Cummel Moor was identified and business cases go back to 2018. So it is a long-standing piece of it's a long-standing programme of work and requires significant capital investment, and it does require certainty. But I will say no more on that at the moment, and I'm very happy to take questions. And I will pause there before I give the overview of the primary care at scale project.
Thank you. Any questions or comments for Teresa? Nope. Thank you, Teresa. Please carry on.
Primary care at scale. So if I just give a brief overview, and I'll probably invite Oliver Radford and Dr. Ellis to supplement what I say. But the board will recall that the primary care at scale strategy has been signed off. So we understand the direction of travel over the next 5 years, and there is what's called a target operating model. So we know where we're heading, and we have a clear strategy. When the business case for primary care at scale came to the board, which was in February of this year, the overall quantum of funding that was being sought, Manx Care could not support it at that time. It was circa 18 million. And that's because we did not have the finances in order to continue with the revenue consequences of that on an ongoing basis. Equally, there was acknowledgement that certain parts of the target operating model needed to be stabilised first. So what the board asked the executive to do is to work on a stabilisation plan, and that stabilisation plan has 7 broad pillars. Now, I think it's probably fair to say we would have preferred to have been a little bit further on, but we are seeking funding through the transformation programme in order to get additional capacity into this really important piece of work. This is something which cannot sit on the side of a very busy team's day job. We need dedicated individuals leading this piece of work, and as I say, we've put in business case through transformation to be able to secure some non-recurrent funding to enable us to take some of this work forward. But broadly, those 7 pillars are a virtual GP solution, which will offer some resilience into the system. The opportunity and the need to stabilise community pharmacy, and that's a piece of work that I've been directly involved in as we've seen the commercial transaction with Lloyd's Pharmacy, and also detailing the types of services we would want pharmacies to deliver going forward. So being very clear around that, or supporting that commercial transaction, which we're not directly involved in, but making sure it does actually deliver what we need to, with a supporting transformation plan underneath it. The ability of our locality hubs, the 3 hubs that we have already, to really be more closely aligned with primary care. And those hubs have moved from social care leadership into health leadership, and there's a programme of work there, and we're seeing some good outcomes there. Also linking in with our local area coordination, so our voluntary and community sector, particularly up here in the north. We committed to be able to offer a salaried model for those GPs that wanted to explore that with us. So this wasn't saying we, as an organisation, absolutely wanted to move to a fully salaried model and away from GP contracts, but we wanted the opportunity. And obviously during that time, we have since taken over the running of Ballasalla Medical Groups, and Manx Care now runs a practice in its own right. And again, those discussions are taking place. There has been a piece of work to identify what services can and are appropriate to shift from secondary care into primary care with a funding stream. And there are there's some work going on around shared care and prescribing in CAMS as much as and other services too. It is an iterative process, and it does need strong joint discussions between both primary and secondary care. We are committed to deliver the improvements identified in the Care Quality Commission reports of primary care, and there's a work stream focused on that. And then there are those broader prototypes to support primary care at scale. So the first contact practitioners, the first contact practitioners for mental health, pharmacy, and the GPs with extended role in dermatology. So that broader range of professionals who support primary care. So that's where we are more broadly. I think it's fair to say we would have liked to have been a little bit further, but I do think it was important we took this step to put some stability into primary care, and then agree how we take forward that longer term ambition, which I think the board still very much has, is around that longer term strategy for primary care at scale. I'll probably invite Dr. Ellis and Oliver to sort of say anything else, just supplement.
No, thank you very much. So I think that's a good summary. I think we've certainly been, over the last year or so, I think we would like to have been a bit further forward. I think we've been on a voyage of discovery between the GPs and Manx Care, really on really the true level of complexity and the number of moving parts that come with PCAS when we're moving towards the target operating model. And I think that the way that we're structuring it now with these 7 pillars is a really positive way of focusing what work needs to be done and what the ask is from Manx Care and what the views are of the professionals. And I think it's a really positive next step that we're going to be getting some project management support, because as Teresa has alluded to, it's not things that this is not projects that can be done on the side of people's desks. This is big work, and this is really important work that, if we do it right, and we intend to do it right, will set the foundations for great and excellent primary care on the Isle of Man for the next generation, the next several generations. I think it's I think the summary of where we are is accurate. I think that there has been a little bit of movement, hasn't there, for the left shift. So we've got CAMS shared care, drug and alcohol shared care. That's just coming into operation now. FCPs, the FCP physio, my conflict of interest, my wife is an FCP physio, and has been working on this project. That is now being rolled out, and we've heard very good things about it. Pharmacy and mental health is not far behind, and I think it's really helpful coming here and listening to what Paul's saying about assurance and quality, and seeing there's lots of opportunities here to kind of tie in to the wider Manx Care requirement for assurance of good governance, of quality. And we're working together really to see how general practices, as most of them are individual businesses, can plug into the overall assurance, so that the board here will be able to have a bird's eye view of not just what's happening in Manx Care owned properties, but the health service more broadly. And I don't think I've got that much more to add, really. I think we're gonna sort of really be able to make some great strides once we've got our project management going. I think we'll see some good moves in the next months, in the coming months.
Thank you, Oliver.
Nothing much more to add, really. We've known for a few years that the GP primary care system is under huge strain, and despite the healthy pipeline of GPs coming into partnership on the Isle of Man from our local training programme, it just hasn't been enough to satisfy the attrition rate out the other end. So, this is as Ollie said, this is a project that will get primary care into the right model for the next generation, using alternative pathways such as the first contact physiotherapist, first contact pharmacist, and the first contact mental health, as well as trying to right size the overall capacity of primary care and make sure that people are being seen in the most appropriate location, whether it's primary care, hospital, whether it's a community pharmacy for their pharmacy advice or minor ailment service or a different service. So I think now that we've starting to get a bit more resource in to support both the project and also the primary care network, I think we'll start to see some real acceleration in terms of the outcomes of what we've been working on over the last couple of years.
Thank you. Any comments or questions? Tim?
Just a comment, really. It's really good to see that we've managed to unlock the resources which are needed, and I know that's been something which has been immensely frustrating for primary care colleagues, but these projects have been ready to go for some time, and I think it's really I'd like to welcome that, but really important that the board continues to focus on ensuring that the resources are there for these projects, because they underpin what Manx Care will be providing into the future, and they underpin all the work at the hospital and elsewhere, and can't have one without the other. So just really welcome this, and would just really highlight the need to continue to ensure there's adequate resource.
Thank you. Any other comments or questions? No. Okay, thank you very much indeed. We're running slightly behind time, but I think I will give us our 15 minutes of our refreshment break and ask the board to reconvene at 5 to 11. Thank you.
Thank you.
Right, I'm calling us back to order and on to my colleagues who chair the committees of this board. We have the papers in our pack, and therefore I would appreciate it if colleagues could just draw to our attention any matters of escalation or things that we should note. So, Tim, I'm coming to you for the first two, please.
The reports you see are in the pack. They're quite full, and there's nothing for escalation on either of the two committees which I chair. I don't think there's anything that I would want to add.
No, I don't think so. Paul, was there anything?
Oh no, sorry, forgive me.
No. Thank you. Nigel, there's an awful lot to say about FB&C, but perhaps at this point you'll just raise those points of escalation.
Well, I'll keep it quite brief if I may, Sarah. Yeah, we met in July. We talked about a number of things, as you can see from the papers, but clearly the main issues for escalation to the board is the 24-25 funding strategy. It might seem a little unusual to be talking about the future here today when clearly we need to deal with the here and now as well. But we have submitted our bid, and the board blessed it yesterday, our full bid to the department for the funding strategy for 24-25. As you know, we've provided a number of options, but the feedback we're getting is that it's difficult. There's a lot of tension in that space, and I guess we're going to talk about it more fully as the meeting goes on. And of course, I'm reminded of the messenger from Greece who brings good news and gets a sack of gold, brings bad news, gets his throat cut. The June management accounts are still intimating and indicating a deficit which is substantive, and clearly we need to begin to take measures to see if we can address that quickly. And of course, I'm mindful of the fact that we have a limited period of the year left in which to address that, but the tension and the pressure on both us as a board and on the department as our stakeholder is great at the moment, and so we're going to widen that out into a full discussion as the meeting goes on. Thank you.
Thank you, Nigel. Katie, coming to you, please.
Thank you. So I'm just going to focus my remarks, if I may, on the Manx Care record. The other things are progressing around data and so on. I don't wish to dwell those. Manx Care record is really starting to worry me. For those who are unaware, there has been an exercise to try and to go into partnership with Liverpool on the procurement of an electronic patient management system. It has been in discussion for a very long time. In parallel to the conversations we're having with Liverpool, excuse me, there's also obviously a conversation with government about the cost of this, because it's going to be substantial. I don't want anybody to walk away from this thinking that we can do this with a couple of tin cans and a bit of string. We can't. It's unfortunately, we're getting to the stage where the time that it's taking to partner with Liverpool and the time that it's taking to extract not even funding, but the promise of funding from the government, it's getting too long, and there are systems that are starting to expire, and we will need to replace them. Originally, Manx Care Record was going to replace those, but we're getting to the stage now where there will be significant risk to certain outcomes if we don't replace those systems. So I'm very concerned about it. It is a red flag. We have to go now to Plan B, I believe, and Plan B could be one of two things. It can be piecemeal, which just goes against every fibre in my IT being to replace things as they fall over and be in the same situation as we are now 5 years hence. Or we try and be bold and we try and convince the government to help us put in a whole package solution. And I noticed in one of the questions that was submitted for the board in advance from the members of the public was about electronic prescribing. Well, that would also come into it, you know, to have the right system in place. All these things would come into the framework. So I've unfortunately I didn't get to the island as fast as I'd hoped yesterday, and I was going to have a chat with Simon, but I haven't had that chat yet. But my advice, Teresa, is that we are now looking to control our own destiny. And that may be still partnering with somebody, but it may be partnering with somebody who already has this done, as opposed to starting the procurement process. My advice would be now to start, okay, we've run out of time now. What we need to do now is find somebody who's got an integrated model working in the UK and basically become part of that instance, and that would be my recommendation. That's quite a high-level thing to say, and there's a lot of work that goes underneath that. But I do think that that's the point that we're at. So
can I just comment on that? So I think it's probably important, particularly for new members of the board, just to sort of articulate that the sort of ownership of the Manx Care Record is still very firmly sat in the Cabinet Office Transformation Programme. That's where the ownership of the specification, the procurement, and indeed sourcing the funding for the Manx Care Record currently sits. There's a long-standing agreement which says once the system is procured and the funding is sourced, it then hands over to Manx Care for implementation. So I think, but I would completely agree that the Liverpool option is looking less and less likely to be a preferred option for us, and we have to sort of look at those contingencies. Against a sort of a wider discussion about the Cabinet Office Transformation Programme, where that sits, how that's delivered, I think we probably need to escalate this to a board-to-board conversation with DHSC, who in turn can bring this matter to the attention of government and indeed Treasury. And I think there's D&I committee in 2 weeks, I think.
I think it's next week.
Yeah, where I think what we should ask the operational teams is to very much flesh out what those contingency options look like, to have a full discussion at D&I committee then.
Thank you.
Thank you, Katie. I think it's very disappointing that we are where we are and it's taken so long. And I think, you know, the people of the Isle of Man deserve an electronic system.
Absolutely.
Because, as you say, it will enable so many more things to happen. So I think if we can ask you to take that back to your committee with the support of the board to escalate that then back to the department.
Sure thing.
The People Committee...
Sorry,
Oliver. Yes, of course.
I'll be brief. So, I mean, the Manx Care Record, as I've said before, is something of a barrier to quite a lot of what we want to do. So it's important that we push through. I think based on my experience as a GP of quite a lot of different clinical record systems, I think it's really important, even if we're trying to get this implemented quickly, that we make sure that we get it right, and that's about speaking to the stakeholders, the clinicians, the staff, and the patients, and making sure that we have the ability, if there's something wrong, there's contractual levers to make sure that it can be fixed. And I think there's been experiences of where things are not quite right, things have been implemented, but actually there's no ability or there's no clear path to getting things corrected or finished. So, I mean, I think that we need some quite clear specifications and very detailed specifications. I know IT procurement contracts can get very, very detailed, 99% of whatever it is uptime, how many milliseconds responses should take. And I just think we should be thinking very carefully about how we specify it if we are going to diverge from Liverpool.
Yeah, and just to pick up on your point, there's two parts to what we're talking about. There's the implementation and there's the run. And the run piece is as important, so we need to make sure the support is in place, not only to maintain the system, but also to make sure that any tweaks that are necessary are made under a controlled change environment. So implementation and run, two separate things, both very important.
Thank you, Oliver. Thank you, Katie. Nigel.
Thanks, Sarah. Yeah, so I sit on Katie's D&I committee and she sits on finance and performance. And I think what I wanted to just stress is there is a huge knock-on to our cost base in this area, because to do nothing is not an option, a double negative, because the old systems, the legacy systems that are beginning to be non-fit for purpose are going to cost us a fortune to maintain. So it's one of these very difficult situations where can we afford to do it? We cannot afford not to do it. And that's the issue, because it is the enabler to so many of the good things we heard about in the first meeting this morning, about the good things that are happening here, and almost one could describe them as self-congratulatory. Not at all. A lot of hard work, but celebrating good things. And this is a massive block to the enablement of us moving forward as a jurisdiction. And a digital solution, not the computerization of processes, but a digital solution. That's the key.
Yes.
Teresa.
Yeah, I think there's just a fundamental question in that Sir Jonathan Michael's report had 26 recommendations. This was one of the very clear recommendations of Sir Jonathan Michael's report, which was unanimously supported by Tim Wold. There is nothing we have since received which suggests we are deviating away from those 26 recommendations, but it appears that the funding for a Manx care record is elusive, and with everyone's best efforts in the transformation programme for the best part of 2.5 years, we still do not have any funding secured or indicated to pursue the Manx care record. And I think that's a much more fundamental question before we sort of discuss specifications, because we could be discussing something which potentially is never going to happen. And I do think that's a very direct question we should be asking. Because there's been a huge amount of work already done. We've all recognised the absolute value of the Manx care record and the quality improvements and efficiencies it will liberate, and the do-nothing option is just highly costly. So I think we just need to ask that fundamental question.
Yeah.
Is this going to happen or not?
Yeah, agreed. The People Committee report is in front of me, but I'm afraid not in your pack. And the item for escalation is on our agenda, which is the pay update. So that report will come to you with the minutes. Apologies that you've not got it. CQC assurance report.
Thank you, Chairman. Chairman, I will spare the board from repetition, but just invite the board to acknowledge, particularly on pages 1 to 10, the incredible amount of work that has taken place over this last year in response and in preparation for the CQC visits. But just to add to the things I mentioned this morning, some other areas where we've also put a huge amount of effort and we're seeing the benefit is in relation to VTE, which is venous thromboembolism, thromboprophylaxis, which is the assessment of patients' risk of getting blood clots and how we manage them. We've done really well with that. As you can see, we've got some very high reliability outcomes and performance is excellent. We also, as you know, built the quality dashboard which from absolute nothing to having something to something that now feeds the IPR and gives us statistical process control is quite exceptional progress. I'm really proud of the work that people have done to generate that, and they do that every month without fail. That's phenomenally important to us. We also established the governance support unit, which was bringing all the various people who work in governance roles into one team where they can get peer support and help each other, and we can train and develop their practice as one group of people. That's taken shape really well and starting to show benefits. As you know, we've got the operational clinical quality group for health and for social care. Those two groups are up and running, and they report every month into the QSE, which is Quality and Safety and Experience Committee. I touched before on policies and procedures, but in this paper I highlight just how much we have done and yet just how much we have yet to do. So we've more or less dealt with 500 documents that in the last year needed to be prioritised for review and approval. That in itself is a monumental task. That's more than one a day. But we've still got 1,500 to get through. So this is one like the fourth bridge. It's going to keep going and we'll keep working on that one. And then last but not least, the incredible work that we've done to establish a mortality review process, which I know Marina will talk to if needed. But this was something we started with Sri and finished with Marina and Ishaku, and is now embedded, particularly at level 1, which is a massive step forward from where we were. So lots of great things that we've already done. Those are in the bag. They're nailed down. We report in this month on those actions that were due for completion in August, and each month thereafter I'll just do a similar kind of report, but picking up the things that are still outstanding. I think we've made actually quite good progress overall in August, but we have got some areas that, if I can ask for the board's permission just to take offline, because my colleagues had a meeting after this report was produced and I've yet to get an update from them, so there may be some changes to this. But in relation to the areas that we need to address, the refresh of PIP, which is the information system, it's the staff record system, it's out of whack or out of alignment with the health roster models and the workforce models, and therefore our budgeting. So one of the actions in the CQC plan is to refresh and rebuild PIP. That's probably going to be quite a substantial undertaking. It's flagged as red because we haven't yet got the assurance that it's been done, but it may need to be readjusted in light of a more realistic timescale. We make reference here to the mandatory training policy. Whilst as an organisation we have agreed a revised policy, it's not taken us down to the core 10, as Teresa mentioned to earlier on, and there's still some work to do with that. But I won't be happy to say that's okay until we start generating assurances that says it's okay. And so it's more of an outcome-based action than an input-based action. We need to be satisfied as a board that our staff have completed. And so there's work still to do on that. There are some areas where I'm seeking further information. So one of those is in relation to the development of a standard operating procedure for the control of substances hazardous to health. My information is that that's in progress, that Jackie and Aaron have got that in hand. I haven't had an opportunity to just touch base on that one, but again, when I have that SOP in my hand, we'll be able to turn that to green. We need to just verify that the management of thermal regulation of water in some of our care home premises and premises operated by Manx Care inside social care, that we've got the verifiable assurances. This was an issue that the CQC picked up, which was, in my opinion, something that the risk was very low, and they're touching on the risk of Legionella, and generally speaking that is a higher risk when water sits in big vats on top of buildings for long periods of time and it's static. It doesn't generally happen in people's homes or residential areas, but nevertheless we're working on it. And then obtaining assurance from our dental providers. It's a conversation I'll have with Oliver outside the meeting about just verifying that we've requested from our dental contractors assurance that they're complying with the relevant health and safety procedures, and as soon as we have that information we'll be able to turn that green. So overall, all in all, I think we've made good progress. We outlined by the domain the status of the plan, and I'll spare you from me going through each one, except to say that some areas are easier than others to implement, and as you can see, we've got some challenges, particularly in HR, particularly in estates, particularly where we're dependent on shared services. They represent a greater challenge, and those actions that are dependent upon an expectation of resource being available are being flagged as amber red at the moment, but on the board's behalf, I will be taking a much closer examination of what is dependent on funding so that I can inform Jackie and the board on where we think our funding requirements lie. And then we can make a decision on what is appropriate for the organisation and circumstances. So it's the start of the firing gun, if you like. This is our first report. I hope that the board will be content for me to take this through the Quality and Safety Committee from this point forward, and to the Department of Health through their quality meetings on the board's behalf. I'm happy to take questions.
Thank you, Paul. Any questions or comments? Tim.
Can I just ask about, you touched on the funding issues. Many inspection reports, all with recommendations, and we've done quite a lot of work, but a lot more work to do. What's your general take on the resources available to implement this? And while that may not be specific resources, it obviously takes away resources from other pieces of work to implement these particular actions. So it's nothing is without any cost.
No, and I think that's a very good point. I suppose I was making reference to a financial amount to transact an action. At the moment, we don't have a budget allocated for the implementation of CQC. And if Jackie were here, and Ash may comment on this one, I think in fairness, that is dependent on myself and my exec colleagues being more direct and clearer on what we think the ask is, and more challenging. So estimates have been provided by some of our colleagues, but they're not credible in some cases, and that's why we've not included them in today's paper. But you're absolutely right. I think some might see the implementation as quite demanding, because we are going to implement this plan and it won't be negotiable unless the board decide it's not implementable. But until we reach that point, we will be delivering this programme, and it might distract people from some other things that they would like to focus on. And if that happens, I think we'll make an assessment of the risk, but expectation is we will deliver this.
Thank you very much. And just from the Equality Committee perspective, yes, we will pick this up. It will be one of the items in the report which the board gets. But I think it might be useful for the board to put a marker down to have a report in 6, 9 or 12 months.
Yeah.
Just to inform ourselves and assure ourselves as a board where this very important piece of work has got to.
Yeah, I was going to suggest that we had a quarterly report here, Paul,
Yes,
and then it goes through QSE the rest of the time. And as you say, any issues of escalation, Tim, will come through that mechanism anyway.
Thank you.
Teresa.
This is only a suggestion, but I think the suite of annual reports that we've started to see come through, the safeguarding report, the SI report, the complaints report, I'm always minded that we have a little bit of a legacy of a lot of inspection reports not necessarily having a history of the actions being followed through and delivered, and colleagues who've been with the organisation a long time repeat this. And I do think this board would want to set a very different ambition to make sure that, as far as reasonably practical, we have always delivered against improvement reports, external, Ofsted and CQC and others. And I wonder whether this board is minded to produce an annual improvement report which very categorically identifies the improvements that we have made against external inspection. To put something on the record, to provide assurance to the public, and to really give confidence, I think, that when we hear these things, we do take it on board, we do learn from these reports and do implement change as a result.
Katie.
So yes, but I think that needs to be part of the annual report. I don't think that needs to be a separate thing.
So just be very explicit in the annual report.
Yes.
Yeah.
Tim?
Yes, and that bit is taken across to any public-facing report as well. So it's very clear for members of the public who don't have the will capacity to read 300 pages of an annual report, to be able to pick out in quite easy, straightforward terms, we've had these inspections, this is what we've done, and this is the outcome. I think that would be really helpful. Yeah.
So I am presuming that it is too late to put that into the annual report that we saw yesterday.
Yeah, and it would reflect last year's. So I think it's maybe something which we just make sure we have built it into the planning and the compilation of the next year's annual report.
So I wonder whether, therefore, you could consider whether you want to produce a separate report for this year with the ambition that that becomes part of the annual report for next year. So perhaps just have a think about whether it is important for this board to recognise the amount of work that's gone on, the amount of external scrutiny there's been, and the assurances that we can take and the progress that's been made. I think that would be beneficial to the board for this year, and then, to Katie's point, integrate that into the annual report from next year.
Yeah.
I think it's so important in light of things that have happened within the NHS in the UK that the board is very, very clear on those issues that have been brought to our attention and the work that's been done in response, because we need to, as Tim has said, very clearly provide to the population of the Isle of Man that we have made improvements on the back of external scrutiny. Thank you, Teresa. Oliver, are you going to start us off on the IPR?
I can do.
Thank you.
So for my section, I'm just going to do my usual three things going well, three things which are proving challenging. To start with, connected to James's initial staff story about Synaptic, just a quick update on how we're going with Synaptic. So overall, we're still continuing to reduce the inpatient and the day case waiting list. So in the last 12 months, we've reduced the inpatient waiting list by 27% and 31% for day cases. In particular, in each individual specialty, 83% reduction in the ophthalmology waiting list, 31% in orthopaedics and 17% in general surgery. But for those last two specialties, we've still got quite a way to go in terms of reaching our target, because we are tracking to complete Synaptic work around the middle of Q4. We've continuing to improve the length of stay for orthopaedics. As James mentioned, the enhanced recovery after surgery programme or pathway for hip and knee replacements is continuing to be implemented, and our current length of stay, the length of stay for August was 1.1 day. So just for those people who are admitted in the morning, they're essentially going home the following morning after initial physiotherapy and assessment before being discharged, which is great. Second one is around ED performance. We're continuing to see an improvement in our ED performance in terms of 4-hour target compliance. So we've seen an improvement. So year to date, we are performing 73% against the 4-hour target. The previous year was 68%. And that's despite the last 3 months. So May, June and July being the highest, the busiest 3 months we've ever seen in ED, which is, interestingly, because we thought we had a really bad winter, but actually our spring and summer has been equally as bad or even worse, but we're managing to hold our own in terms of that performance, and we are on par with the UK performance. We're essentially exactly the same, but that's despite our ED being significantly smaller than the recommended and a number of those services not available. So what Teresa mentioned earlier in terms of what has been funded, the same-day emergency care, intermediate care, etc. Although they're on the horizon, they're not here now, but we're still continuing to see an improvement, which is heartening as we are moving towards the winter period. The final thing in terms of what's going well is around our enhanced waiting list management programme. So we've validated over 15,000 referrals through that programme and removed just over 14%. That is a combination of patients who were maybe on the waiting list twice or could be administratively removed, as well as people who have responded to our validation letter saying that they want to be removed from the waiting list because their symptoms have resolved. And we're moving into the clinical validation phase of that. So within orthopaedics, ENT and general surgery, we're starting to clinically validate those referrals, so that they'll start with the longest waiter, people getting a phone call from the consultant saying, have your symptoms resolved? And so that there is a clinical check on those people who have waited the longest. We've seen a deterioration within our DNA rates for the hospital, unfortunately, but there is a correlation between our longest waiting lists and our DNA rates. So we've realised that is most likely linked to our current administrative processes. So we are pushing forward with our changes to essentially the letters that we send out. At the moment, we send out appointment letters at the time that the appointment is made. Sometimes those letters go out several months before the appointment is due, which we realise isn't ideal because people don't always put them in their diaries and sometimes forget about them. So we will be bringing forward a project to basically send out those letters 6 weeks in advance. And that would also mean that we can remove the cancel and rebook letters that we send out quite a lot of, because that 6 week in advance is the notice period that we require for medical leave. Also, we are in the end of this month going to be piloting Isle of Man Post Office handling all of our posts, so not just the delivery of it, but also the printing of post, as well as putting them in envelopes and delivering. And we know we've identified a few issues in relation to the current way of doing it, one of which being data breaches, because more than one letter at times goes into these envelopes. But with this, they have obviously an automated system doing it. So we're going to be starting that in orthopaedics at the end of this month, but with a relatively short pilot period before rolling it out. In terms of the 3 areas of challenge, I've mentioned cancer waiting times a few times as an area of challenge. They're continuing to be an area of challenge for us in that we're not meeting our current standards across a number of areas. Having said that, we have seen, this is our 3rd month of improvement across all areas. So 28-day faster diagnostic standard, 2-week waits, 31 and 62 days are all improving, which is good to see. I mentioned last time our desire to move to focus more on the 28-day faster diagnostic standard. The NHS a couple of weeks ago actually published the same strategy to be moving away from monitoring 2-week waits as the initial indicator, and moving more to a faster diagnostic standard. And obviously we're going to be doing the same. So it's good that we're seeing a trajectory that is in line with the UK trajectory for reaching the faster diagnostic standard. Second is category 1 ambulance waiting times continues to be an area of concern for us. Our mean response time for category 1 is just over 11 minutes 23, whereas the standard is 7 minutes. As we know, the category 1 calls are the most time critical, so cardiac, respiratory arrest, etc. So we are continuing to support the St John Ambulance around their community first responder and looking at ways as part of the blue light strategy to for other blue light services to provide that initial response so that we can so that people who are who have called 999 or bystanders who have called 999 for patients who are in a category 1 type emergency, so that other resources can be, which is fairly standard within the UK, particularly fire services doing that dual response role. But we're hopeful that the blue light strategy, which is hopefully about to be endorsed between the both ourselves, the DHSC and the DHA, will start to provide a pathway for us to be able to do that. And the final area I just want to raise is the dental waiting list. Teresa mentioned it as part of her CEO report around the handing back of the contract from Hillside Dental Practice, which Regent manages. Since April, we've seen a 14% increase in our dental waiting list. That's 484 patients have gone onto the dental waiting list, which obviously is moving in the wrong direction. I think it's worth mentioning that that the contracts that most of the dentists have don't give us much in the way of contractual levers. Certainly in the first 6 months of their contract, we're not really able to do anything to encourage them to take on more patients if they are falling behind on their performance, which obviously proves a huge difficulty for us. There is a business case going through at the moment which seeks to remedy a lot of that contractual imbalance in terms of us not having many levers to improve the performance of contractors, dental contractors with us. And that is just in the process of going through the business case review group, but that's clearly something that we need to discuss with the DHSC around the overall funding for dental services on the island, because clearly what we have in our budget in terms of the number of units of dental activity that we commission, clearly isn't enough to satisfy the need for NHS dental care. So I think there is some quite some conversations that we have to have with the DHSC relating to the underlying funding for that service and whether there is any other things that we can put in place to try to manage the demand for NHS dentistry, whether that's amending the charges for NHS dentistry or maybe even introducing eligibility criteria, but that is an area that obviously we need DHSC support and sponsorship from. And I think that's it from me. Thank you.
Thank you. Any questions for Oliver? Teresa?
Sorry, I've just got a couple that I think the number of theatre cancellations on the day always seems to be disproportionately high for me, both in terms of clinical and non-clinical. And actually for people to arrive in the hospital on the day of surgery but clearly be unwell enough to have their surgery is a concern. So, and I can't pick it out in the mitigations. Is there any auditing of this that we can do to understand that more, or for people to feel they can ring up the day before if they have a cold or if they've got some symptoms? Because I do think our cancellations on the day is far too high and we should take a focused look at that. My second area is around that cancer pathway. And I think we obviously will always have challenges around clinical capacity, but are we assured our administrative processes on the cancer pathway are capturing these referrals at day one, triaging, allocating, booking, to give us every opportunity of becoming compliant against the 14-day standards? And I know there was a lot of work done on the cancer pathway by the transformation team. Is it something we can look at in a little bit more detail around the administrative processes which sort and support the cancer pathway, to make sure we are doing those as efficiently as possible, to give our clinicians every chance of getting those patients in within those 14 days and achieving the compliance.
I think the first one is that I'm not aware of any audit data, but something that we can certainly do. I agree, we do have a really robust PAC process here. So anyone who has got a medical problem that goes through the pre-assessment clinic will be picked out and the relevant investigations done, so that issue, whether that's a cardiac issue, respiratory issue, whatever, is dealt with, so it doesn't get to the day of surgery. I agree that there may be a reluctance for people to contact and cancel themselves, particularly given the length of our waiting list, and people may have been waiting several months for their surgery and to cancel themselves without actually having that confirmation from a clinician that they can't go ahead might be, but I think we just need to check that data. In terms of the cancer pathways, what we're doing at the moment, what the cancer services team are benchmarking our administrative and clinical processes against the Cheshire and Mersey pathways.
Okay.
And both from because we are aware that there are some triaging delays, particularly where there is single-handed consultants who may not triage. Our triaging for 2-week waits is 24 hours, so that's the turnaround. But we know that there are some areas that are struggling to reach that. So I think what we need to make a decision around within those areas, if the consultant can't review that referral, whether we just process it anyway. We're not permitted through our access policy to downgrade 2-week waits anyway.
No.
So whether that triaging piece is a worthwhile step in the process, or whether those just go ahead. And I have got a meeting later on this week to discuss the whole issue around the processing of cancer referrals, and whether we can speed that up by taking it away from the patient information centre and managing it through our cancer services team that are more tuned to managing cancer referrals versus the considerable amount of referrals that come in through PIC for urgent and routine.
So perhaps we could ask for those to go through the performance and delivery group operationally up to EMC, and then we could perhaps give feedback to the board through the Chief Exec's report at a future date, just on those two matters.
Yep. Thank you. Nigel.
Thank you, Sarah. Ollie, I'm just going to ask you a question, if I may, on this dental health business. This has been on our agenda for quite a long time now, and I'm really quite concerned about it. What is your, I realise that there are some issues with the contract, and clearly that's sensitive, but what's your best estimate of getting this on the road to being fixed? Because it's getting worse, not getting better, and I find that quite offensive in this lovely jurisdiction in which we live. Hearing the good things about what have been going on, dental health and access to it is surely key for our population, and dental education.
Yeah, well, we've worked quite closely earlier on this year with Public Health to develop our dental strategy, which is focusing a lot on early intervention. Unfortunately, ideally there would be funding associated with the dental strategy, so we can start to improve certainly our early dental health. There was unfortunately no funding available as part of that strategy, so a lot of the strategy is more around awareness, more around developing policies, etc. But given that there was no funding, we haven't been able to include anything that is requiring funding, which is unfortunate. I am glad to say that Public Health, after initially discontinuing the Smile of Man programme, which was the programme which went into schools to teach children how to brush their teeth properly. That was stopped, but that is going to be restarting, I'm glad to say. I think around this month, to coincide with the new school year, which was good to see. I think, as I mentioned, the NHS, there is no, like the NHS in total, there is no eligibility criteria for being on the dental list, so being an NHS dental patient. But clearly we have a capacity problem in terms of the number of units of dental activity, UDAs, that we have available across the system is clearly not enough. I think that there is that piece of work that we need to do with the DHSC, that either we, through requesting additional funding, that we increase the number of UDAs that we have available. We have included that as an aspiration within the dental strategy, but realising that that's not a thing that we can introduce in year one, given our current financial issues. So I think it is like a lot of the primary care services that we commission, such as optical services as well, whether there is whether the current model actually is a feasible model in terms of from a financial point of view. I think that there are the contractual changes that we have to make that I mentioned earlier, to make it more, to make Manx Care's power to manage those contracts a bit better, because we don't have those at the moment. And I think there is some things that we can do to streamline the process and make sure that the UDAs that we do have funded are used to the maximum benefit. But I think that will only take us, that contractual piece will only take us so far. I think we need to recognise that there is a funding gap between what we need to satisfy the population and what we've got in the budget. Whether that is a injection of funding or whether that is a change to the eligibility, I think is something that we need to discuss with the DHSC.
So are we just salami slicing rather than transformation? This is what's concerning me, that we don't seem to be getting on with this, and there doesn't seem to be, I know I'm paraphrasing and I know it's wrong, but there doesn't seem to be an imperative to do this, and I think it's just really key that we get on with this and have a timescale for it.
Teresa?
Yeah, I would agree. We've seen the dental waiting list increase. It's clearly a market where we struggle to get practices engaged to deliver NHS activity. I think the discussions that we've had more recently probably suggest the contractual framework does need overhauling, and they're the discussions that we're having with the Department of Health and Social Care and with the Attorney Generals to sort of what are the options for us, because we know that quite a high proportion of those dental contractors are under-delivering against their contract. So they have their own capacity constraints. They're not delivering against the contract that we've put in place with them. And of course, we can't do anything in year. Being able to address that or readdress the finances happens the year after. So we don't even have the money in year to go and do something differently with. And obviously, when you get to the point where big practices are handing back their contract because they haven't got the staff to be able to deliver, it's a sign that we need to sort of think very, very differently about how we deliver that activity for the island. And I think we will need to look at a different contracting approach going forward.
Well, thank you. I mean, my concern is it's privatisation by stealth, and that's the concern, and I think we just need to be very alert to that.
Thank you. Tim and then Oliver.
So, three areas. Just want to pick up on the dentistry and the real importance of that, particularly for people who find it hard to access those kind of services, people with learning disability, mental health, or older people and people in care homes. Again, really important that we've got really good commissioned services which pick up for people who find it difficult to generally access dentistry. I also wanted to pick up, Paul's said quite a lot in other reports about infection control generally. Those are obviously in this report as well. And I just wanted specifically to pick up on the issue of pressure ulcers, which seems to be on an upward trajectory since May. And for that's something maybe that another committee might want to look at in more detail, thinking perhaps the Quality Committee might want to have a particular look at that, because that's obviously part of that. And then the third area was more in terms of the governance, and looking at the performance on the duty of candour, FOI, data breaches, and just seeing the vast improvement which, again, Paul and the executive team have made in the complaints, and just wonder if there's something there we can also do in terms of these other areas of governance which seem to be red and we seem to be failing on. And I just wonder if that can be picked up somewhere in terms of those more governance issues and bring them together, like we did with complaints, and think about how we can have a top to bottom solution for those. Thank you.
Thank you.
Can I respond to Tim? Thank you for raising those. As you mentioned a couple of things I was going to say. So I think the Clostridium difficile issues we've already discussed as a board, and we've got some work to do on that, particularly around bedside furniture and antimicrobial stewardship. I have a suspicion that the rise in E. coli bacteremia is linked to the rise in pressure sores. I think those two things are not separate, but I need to look at it in more detail just to be sure about that. The pressure ulcers is an unexpected increase. I can't explain it at the moment. I don't know why, but I'm working with my senior team on trying to get underneath it. We've had 10 cases in the community and 12 cases in the hospital. It could be linked to a whole raft of things, not least nutrition, hydration. It could be linked to the standard of the mattresses and the condition of the furniture, or it might not be any of those things. I need to look into it in more detail, but I will come back to you on it. And if you're content, I can bring a paper to the QSE summarising the findings. The duty of candour was one breach out of 4 cases, and it was one breach that wasn't dealt with properly. It classified as a breach, which is why the figure is the way it is. I am aware of that. I've looked into it with my colleagues. We have put in a procedure to stop that from happening again in future, but it was an avoidable situation, but it's subsequently been discharged as a duty of candour, but nonetheless was a breach of the timelines. And again, you know, must is almost an always event, given the level of reliability that we've achieved in that, which is great. And I echo your comments about the levels of service user satisfaction, which are really encouraging. In spite of all our challenges, that's excellent, and we are being very responsive as always on complaints. I appreciate that.
Thank you. Oliver.
Thank you. So just going back to the dentistry question, Oliver, if I may, you touched on this, so apologies if you've already answered this question. So there's a certain number of units of dental activity that we have available, and it sounds like we just don't have, there's not enough available for the island. So there's a...
I think there's two. I think we haven't got enough totality of units, as in funded, and then of the contracts that have been issued, a number of contractors are tracking below what we would want them to deliver for us.
So, and we've spoken about how that number can be increased, but I guess that's not an immediate, so that's nothing that's going to happen immediately. So in terms of what we've got at the moment, is there some process of allocating those that exist to specific areas, to where the areas are that there's the most need, or is that, do we not have that level of control over how they're allocated?
No, well, they're allocated based on the contract. So that I think there's probably about 11 contractors on the island, and they each have a share of the UDA kind of pot. Some of them are quite big. So Hillside, for example, is quite a big practice, 6,000 patients, I think about 15% of the UDAs. Some of the practices are quite small, so they only have a small amount of UDAs, and so they're you know, the proportion of NHS to private is differently.
So I think sorry, what I mean is in terms of making sure that those patients who have the most need are have priority for the units.
No,
that's not something that's possible.
No, well, no, you know, as we've said, we're running a system where there's two contracts. There's some providers that have got a contract that was signed in 2003, and it's a bit like pharmacies. Those contracts can be passed on, so they're essentially the contract is linked to the practice, but that practice could be owned by a number of people since 2003. So that essentially the contract is kept in perpetuity, and the contract doesn't provide us as the commissioner with many levers. So I think our briefing from the team within primary care indicates something like we can within the first 6 months the contractor only needs to deliver 30% of the UDA value in order to be compliant with the contract. We are looking and we are speaking to the DHSC, and we covered it at our quarterly mandate meeting around how we are able to almost throw those contracts away and start again, and obviously that's something that we need to discuss with the DHSC in more detail, because clearly it's not a good use of both public money and resources. You know, when people are, you know, there's 4,000 people on the waiting list needing dental care who are only able to access it through our community dental service, which we run as Manx Care, operated out of the Central Community Health Centre. They only deal with emergency patients, so we obviously, you know, the beauty of having an NHS dentist means that you can have regular checkups, so you don't have to get into a dental crisis in order to access, because, you know, clearly the early intervention is much better in terms of maintaining people's oral health. So I think overall the situation is unsatisfactory, and something that we need to work with the DHSC to resolve, because you know, all of these NHS dentistry, contracting, they're all covered within the regulations which we would need DHSC concurrence to change. It's not something that we can change on our own.
No.
So.
And it is something that we've, as you say, escalated through the mandate meeting, and I've escalated to the Minister in my meetings, and I know Teresa's done that through the officer route as well. There are so many things about what you've said that are not right. But in the interest of time, I think we will acknowledge here that, you know, as Nigel has quite rightly said, access to dental health is vital. And as we've discussed in other reports, delaying people having early intervention just stores up future problems. And I think we are acutely aware that we need the support of the department to enable those contracts to be fit for purpose. In the interest of time, I'm going to ask colleagues who have other areas of the integrated performance report to just raise issues of escalation, if I may. David, if I come to you first, and then to Marina, and then to Paul.
Okay, thank you, Chair. So in terms of escalation, I think we have a number of business cases already in the pipeline and going to Treasury that will address hopefully some of the waiting lists and some of the concerns we have around mental health in particular around that. I think in terms of social work, we've had quite a bit of success now in terms of recruitment, so we're seeing waiting times falling, which is good. We still have an issue around the length of time it takes to complete assessments, particularly on complex cases beyond 28 days, but we're working on that. I think other issues we're probably have in hand, Chair, if I'm honest, in terms of resources, recruitment and plans going forward. So nothing we need to escalate.
Thank you, and well done on the recruitment. That's been something I know that you've been focusing on. Does anybody have any issues that they wanted to raise with David, or questions? Marina?
No, I've got nothing to escalate.
Thank you. Paul?
I thank you, Chair. I've been able to raise my points.
Brilliant. Thank you very much. That's been very helpful. Who's going to update us on the pay negotiations? Shall I do that? Thank you, Anne.
So we remain in dispute with the Royal College of Nursing for the 22-23 pay award, which they represent quite a significant proportion of the Manx pay terms and conditions body of staff. They rejected our most recent offer, which was 6% plus a £1,000 consolidated sum added to each pay point, and they got a mandate for strike action from their membership, and as you know, that took place, and they advised us of an intention that that would be discontinuous industrial action. So I think we're at very high risk of further strikes. We remain in discussion with both the RCN and our consolidated staff side, but I think through those discussions, I think it's accepted, I think, would be best we put it by the staff side, that Manx Care has exhausted its funding part in terms of what it can offer for pay awards. And yeah, so to a certain extent we're at something of an impasse, but we are keeping the discussions going.
Thank you. Teresa, do you want to add anything?
Yeah, so I think just, so the MPTC NJC, Manx Pay Terms and Conditions, are just one group of staff. For medical and dental staff for last year, we did settle, which was welcome. And for Public Services Commission, again, that was resolved. I think the concern we have is that for the Royal College of Nursing, and by default that wider MPTC group, we are still in dispute from last year's pay award. We have not been able to resolve it, which is obviously means continuous industrial action from the Royal College of Nursing. With regards to this year, as at sort of month 5, we were allocated 2% in our base budget for pay awards, with the expectation from Treasury that organisations would find the remaining gap as to whatever was able to be settled with staff side organisations. Now, in order to offer that extra £1,000 consolidated to resolve last year's pay dispute, which it did for the majority of unions, we had to use that 2% that was in this year's baseline. So as it stands at the moment, we have nothing within our base budget to offer staff in terms of a pay award or pay offer for 23-24, and I think that is a very difficult position for us. We are seeking the support of DHSC to escalate that as part of our financial work to look at a back to balance plan. We are looking as to how we can identify enough headroom in the budget in order to put a pay award on the table. But just to sort of give the board a sense, if we were to sort of look at a pay award of around 6%, that is sort of in the order of £8 million for the organisation to find and able to offer that. So it is a substantial amount of money in order to sort of start those pay negotiations for 23-24. So it is a significant risk that the board need to be cited on. And as I say, I think given our financial position, which we will come on to talk about, we do need to be escalating this appropriately to have those discussions with DHSC and broader government about how we resolve this. I think one of the difficulties that we have as Manx Care is we do not necessarily understand the broader position across all professional groups on the island. So we don't know whether other groups are in a similar position to ourselves of not being able to put an offer on the table, or indeed how our offers compare. But actually I think we again have escalated that to be able to have that broader understanding. I'll leave it there, but I think it is one of our significant risks that we are not able to put an offer on the table for around 2/3 of our staff. For our Public Service Commission colleagues in the organisation, which accounts for about 1/3 of our workforce, there has been an offer placed. It is negotiated directly by government, and I understand that offer has been rejected, but again, I think it does create a little bit of inequity for Manx Care that some of our staff will have received a a pay offer for 23-24, some haven't. And I think that's, again, quite a difficult position for us to manage in terms of communication with our workforce, but also really working to get some resolution on that and secure services.
Thank you, Teresa. Any further comments? No. Thank you. So, staying with you, if we may, for the people, culture and engagement strategy.
Yes, thank you. We've obviously recognised since Manx Care's inception the need for ongoing cultural improvement, to have a people strategy. And so I have been working with a wider group on putting a people, culture and engagement strategy in place, which sort of covers the next three years. This has been in development for around the last 4 to 5 months. We have consulted with a wide number of internal stakeholders, so the Executive Management Committee, the People and Culture groups, the clinical directors, the executive leadership team. And we did take the opportunity to consult on the draft strategy with the whole organisation through the consultation hub for a 3-week period during August. So the document here creates a aim of building a fully engaged, inclusive and high-performing workforce that lives our care values. So our mission statement and has 5 strategic workforce and culture ambitions, which are, described there. The deliverables of the strategy very much reflect what has been incorporated into the workforce and culture team plan for year 3. Elements of improvement and policy development that have been identified through OHR and in discussions with our partnership forums, and indeed our own internal sort of communication and delivery ambitions, which have been coming through the People Committee as a result of the listening exercises. The feedback from the consultation hub was broadly quite positive. A lot of staff identifying with the strategy, feeling they were broadly the right things for the organisation to focus upon. I do think we will need to sort of update this and keep it as quite an iterative document. I know it says a strategy, but we are about to go and undertake a large organisational survey based on the NHS survey. And I think that will be the first all organisation-wide clear baseline from which we can understand whether we've got the right things in this strategy and update it iteratively. But I do think this is broadly the right things which we have had long discussions about in People Committee and has been through a reasonable level of engagement and consultation. And so I've brought it today to the board for approval. Please.
Thank you, Teresa. It's really good to see everything in one place, and notwithstanding the need that it may and should be a living document and need to be updated, I think it's really excellent to see that piece of work brought together. Does anybody have any comments or questions? Katie?
Just that I think it's thorough and tangible. Very often these plans can be a little bit sort of esoteric, for want of a better word. But I do think there's some tangible things to do in there. I like the fact that it's split by year and there are recognisable ways of understanding whether or not we've achieved it. So I think we're in good shape. Well done. Thank you.
Tim?
Yes, I welcome this, and I think it's a massive challenge given the diverse organisation which we are to have one plan which goes across a whole range of groups of people, those based within institutions, those based outside of institutions, those based in very small teams, those based in larger teams, and for staff who are highly paid and highly regulated to staff who are less well paid and not regulated. So I guess the sting in the tail is what's your take on the involvement and buy-in from our medical staff, for example, but also for our the social care registered staff, again, as two different groups of staff with, I guess, quite different views.
Yeah, and you know, I would agree that we've got such different areas and trying to meet everybody's expectations. One of the questions because one of the things that I was very conscious of was that the language felt right and the language resonated in the different areas of the organisation. And social care always is the one that comes to the forefront of my mind. Is the language we use in this document, does it resonate with social care staff? You know, there were some very interesting free text comments, as you can imagine, when you put some things on the consultation hub. But actually, sort of between 2/3 and 3/4 felt the language did resonate. And I think people acknowledge this is a first attempt for the organisation to really define a culture strategy. It's something we will continue to build on. You know, so one of the things Marina and I have recently agreed is we are going to run the Civility Saves Lives programme and bring that into the organisation, because we know that will naturally resonate with clinicians and they'll see the purpose of that. I think, you know, I know David's been working for a long time on the sort of internal cultural matters in social care, and they will be different. I'd like to think, there's something for everybody in here. And you can pick the bits which will really resonate with your areas and that need to be driven harder in your areas, and the areas where you can sort of accept that there's a different solution in different areas. I think the art will be in the monitoring, and to make sure we are finding really good ways of monitoring the impact in the various areas of the organisation, and continue to use the workforce and culture team to go in and do those deep dives. And as I say, you know, I think there's probably a healthy degree of scepticism about some of this from some quarters of the organisation. I see that, I hear that. But I think we have to start somewhere and keep building on it.
Yeah, absolutely.
Thank you very much.
Yeah, it's nice to see this come through, Teresa, because it's been a kind of long time in the coming, I think. I think there is an element of interpretation in there, which is fine. I think that's always going to be the case. But for me, the next stage is about, so how do we make sure that at a team level and a kind of management level, we are then working on this to make sure that we are contributing towards the delivery of the strategy at a very local level. And I think we can do that, and we've started doing that already, to make sure that that alignment is there and that we are contributing towards these kind of outcomes, the key outcomes that we want to achieve. So I think it really helps us to have that kind of high-level strategy.
Thank you. Just one very small point from me, which is that I know that in the strategy there's a suggestion about forming a couple of networks. I think we should be open to having more than just two. And certainly in my experience, staff will very quickly decide which networks are the most important and which networks they want to belong to. But issues of disability, for example, we may wish to accommodate that, and I think we should be open to accommodating the networks that staff say are important and that they would like to establish. So, but we've got to start somewhere.
Thank you.
Quickly, Nigel.
Very quickly, just to say congratulations. I think it's a great document. I think it's a great start as a bean counter, you know, by profession. I'm not always into the touchy-feely stuff, and you'll always get the cynics out there who'll poo-poo it, but I think it's a great start. And I think it's a great move in the right direction, and you're winning hearts and minds, and I think this is key. Thank you.
An amazing sync into our next item, Nigel. So I am delighted to welcome Ash Perry, who's our finance partner, to the board meeting on Jackie's behalf. By way of introduction, we have two documents in front of us, the July management accounts and also a discussion around the financial plan submission. But I just wanted to reflect some of the conversations that we had as a board yesterday, and indeed some of the topics that have already been raised by colleagues as we've gone through the meeting. We are acutely aware as a board of our absolute commitment to prioritise patient safety and care, but we have to manage that within a financial envelope. And we have spent substantial amount of time as a board thinking about how we prepare ourselves for next year, and indeed how we balance the finances alongside our absolute commitment to provide safe and high quality care throughout the organisation. There is always that tension in every organisation about delivery and balancing the books. And I think that we were all utterly, well, I know, I don't think, we were all utterly devastated not to meet the financial balance last year. But it was, as Jackie would say if she was here, between 4 and 3% that we missed it by. So we did record an improvement there. Funding for health and social care across the whole world is incredibly challenging. There isn't a day that goes past that there isn't some news item about it. With ageing populations, shortages of staff in social care and in healthcare, and all the pressures that we are dealing with post-COVID mean that here within Manx Care we have an equally challenging situation. I think there is also, as we have just discussed, issues about what Sir Jonathan Michaels wanted in terms of funding for projects and what we are actually in receipt of for funding of projects. And we've mentioned a number of those already. So we have looked at options for discussion as a board for next year, and we have a meeting this afternoon with the department to touch on those, and then a further dedicated meeting later in the month to discuss them in more detail, and that builds on meetings that have already taken place between the officers. So we are looking at 3 options, one of which is deeply unpalatable to us, which would see us really change the delivery of some services to such an extent that I think we would not sleep at night and would not be able to accept some of those suggestions. They would be so detrimental to the provision of services. We had a second option which we spent an enormous amount of time talking about yesterday, which would see us look at a variance of mitigation for some of the suggestions that were made by executive colleagues, and I am enormously thankful to the levels of engagement yesterday in a lengthy meeting, the commitment that we remade to quality and safety, and the reality of what that would mean in terms of meeting our financial commitments. All of those options are now going back to Jackie and her team to look at the impact or to go through an impact assessment, I should say, so that we fully understand the impact. Obviously, option 3 was to carry on doing absolutely everything and saying to the department that we would have a substantial overspend. And in the same way that detriment to the safety and the care that we can provide is unpalatable to us, it is also not acceptable for any of us on the board to kind of sign off a spending regime that would see us massively overspend. That's what I would like to say by way of introduction. Teresa, is there anything you'd like to add?
No, I don't think so. Thank you.
Ash, over to you to talk us through the documents.
Thank you very much, Sarah. So a copy of the management accounts have been provided within the pack and are on page 194, and included within that as well is the FD's report prepared by Jackie and her team. In terms of the management accounts, I will take everybody here as having read them, so I won't go into the weeds of it. But the forecast itself has remained stable, which is good news following the first quarter of the financial year. And this is despite a number of funding pressures being felt by the organisation, particularly around things such as inflation on drugs and contracts. Interestingly, within the management accounts, this is the first time that the agency spend has dipped below the 21-22 levels, and this appears to be as a result of the substantial recruitment efforts that have been undertaken by the organisation, which were talked about earlier in the meeting today. Moving on from the management accounts to the next sort of item within finance is the 24-25 funding. And this is included on page 3 of the FD's report, just prior to the management accounts. So for the 24-25 funding, or financial plan, is effectively the budgetary ask that Manx Care are going to the Department of Health and Social Care for as part of the next funding cycle. The Department of Health and Social Care will or have reviewed that document, and they then submit that to the Treasury as part of the overall budgetary process for the Isle of Man government. The plan itself has been built around a number of priorities within Manx Care, and these priorities have fed through into kind of a more strategic element of what the organisation would like to achieve in the coming years. And as I said, the Department for Health and Social Care has now submitted this to the Treasury. An early indication of what funding envelope we are likely to receive will probably come from the Treasury, usually around October time, if we were to take prior years as an example. And at that point, we will have the opportunity to discuss funding with the Department of Health and Social Care around what we can and can't do depending on the size of the funding envelope. Many priorities within that financial plan that's been submitted are estimates that have been produced by the finance team in conjunction with our partners in Manx Care, and we'll continue to work on those financial priorities right up to the kind of lead up of receiving the financial envelope. So thank you very much. I think that's everything I have to say.
Thank you. Nigel, as Chair of the Finance Committee, is there anything you want to add?
Thank you, Sarah. I've got a lot to add, but I'm going to keep it very brief for sake of our sanity and also the listeners. I think I want to talk about credibility. I think that we're now in our, effectively, as we pitch for 24-25, we're in our 3rd year of operation, going into our 4th year of operation. I think we all know around this table that the first year was very much a year of discovery. It was very much a vote of huge confidence by the Isle of Man government in empowering a Manx Care board to run the service. But we did discover quite quickly that, and I think this is an open admission, that there were some errors, some flaws in the budgetary process. It perhaps wasn't soon enough, and there were some big numbers out there. The second year, we'd learnt a lot, and I think we were very disappointed not to come in on budget last year. We were caught out at the 11th hour, 59th minute. But that huge amount of money, relatively small amount in the greater scheme of things, I think did damage to us in terms of credibility and understanding in the wider public and the wider government circles, our stakeholders, in other words. And I think the damage that it did was disproportionate to the achievements that we've made as an organisation. And I think that's a great shame. And I still think we're living with that now. Because these numbers that we're pitching for have not been pulled out of the air. They've been constructed. They haven't perhaps been constructed as scientifically as we would like in terms of objective actions and sort of from that perspective, but from a lot more skill, knowledge and understanding of the service, the mandate, where it's going and where we want it to go. Those numbers are really very, very accurate. They're already £80 million adrift from Jonathan Michael's recommendations. Already £80 million adrift. But I think we need to be very acutely aware that we mustn't be seen as whingers. We need to work with our partners. We need to find alignment. We need to find ways in which we can work together. But we also must be honest, and we must be true. And we cannot make some of the real big step forwards that we've been identifying unless we get proper resource and unless we have the proper headroom to do it. And therefore, you know, the danger is that we just muddle along.
Yeah.
And we salami slice rather than transform. And I think that's a massive frustration to this board. It's probably a frustration to the department too. And I think we need to be mindful of that. So, yeah, I'm disappointed that we're in this situation. We'll do our very best. But the only way we're going to take it forward is by getting that strategic alignment of all our stakeholders, Treasury, department and public, and be real and be truthful with them.
Indeed. Thank you. Teresa and then Charlie.
Sorry, I just wanted to just make a couple of points because I do agree with you, Nigel. But I also feel as though that credibility was impacted and masked the achievement of over £7 million of cost improvements of cash out of this system and a further £3.5–4 million of efficiency savings achieved for last year, which, you know, is a huge achievement by any standards, and would have meant a £20 million overspend had we have not taken those actions. I think one of the difficulties and the challenges that we've had to consider, and obviously we discussed it in detail yesterday, is ordinarily a provider NHS organisation has the ability to create savings either recurrently or non-recurrently by things like energy efficiency, selling buildings, selling land, doing things differently that doesn't impact on clinical services. And they're the areas of cost improvement which you go at first because it doesn't impact on clinical delivery. I think the other thing which is very pertinent to this system is if we make changes which tries to curtail clinical delivery on island, we potentially will spend more because actually it costs more to send patients off island for their clinical services. And unless you can find a way of finding that those services are no longer needed or stopped completely, then inevitably those elements of delivery will continue, albeit it will be patients getting on a plane at the expense of Manx care and receiving care in the UK at the expense of Manx care. So it is quite difficult to really get to the detail of what you can reasonably do, which actually isn't going to incur more costs, as well as affecting the clinical outcomes and patient experience, which we've been so at pains to protect and continuously improve. So I did want to just make those points because I do think it adds an extra layer of real complexity for us as a board to consider when we're having to make some really difficult decisions about how we balance the books.
Thank you, Teresa. Charlie.
Thank you, Sarah. As a new non-executive director on this board, I just wanted to feed in a few observations, if I may. I've sat on many financial transformation boards in the NHS and over in England. So the first thing that I wanted to feed back is it's a quip to say that you've reached stability. The position hasn't got worse, but it hasn't got better. But actually, there's a huge amount of work that takes place underneath maintaining stability. So well done for maintaining that position. Secondly, I do actually take quite a lot of comfort and confidence in the finance team in that we're tracking closely to projection. So I observe accuracy in the projections of the financial situation of the organisation, and I think that's a real positive that we should all take away, even if the overall message isn't great. The fact that the tracking is true, is staying true, is good. I also observe that when we have discussions around back to balance and achieving better balance, that there's really good, particularly from yourself, Oliver, as a director of operations, you've got your finger on the pulse. So some of the suggestions and some of the discussions we've been having have knock-on effects, don't they? They're not everybody, that aren't necessarily apparent. So again, I think it's really that there's high confidence in me that you actually know what's going on at the ground. There are suggestions made at board level that you're then able to bring us into that reality check of what that might mean now and in the future. And my final point is we must prevent what happened last year in Q4. And again, what I've observed in the conversations more recently is around really pulling through lessons learned from last year. You know, you've clearly reflected and you're making changes in order to prevent that derailing of your financial situation in Q4. So they're my observations that I wanted to feed in because I'm seeing positive things in what is a rather unpositive situation and narrative.
Thank you, Charlie. Thank you. Does anybody else want to make any further comments or ask any questions? Thank you. So that concludes the formal business of the board.
I was not alerted to any other business. We are in receipt of a number of questions from Mr. Mann, which we plan, well, indeed, I'm in receipt of, I think, almost all of the answers now. So we will share those with Mr. Mann and put them into our minutes as per usual. And Andrew, thank you too for your questions. And again, they're in process of being answered, and we will share those with you in due course and make them a part of our public record. Are there any additional questions from the members of the public? Yes.
Thank you. Actually, I've just got 3 small questions from the IPR. The first one was the pressure source, which you're going to be dealing with, and I wonder if you could ask Sue to send me a copy of your findings when you drill in to see why there's a 40% blip.
Yeah, of course.
Thank you very much. The second one was the mortality review. It's great news that you're really on top of level 1. But in the minutes of July's meeting, you said you should be moving now 20 to 25% should be moving to level 2. And level 2 doesn't figure on the dashboard at all yet. And worryingly in the minutes, it says that the medical examiners are not yet functioning in the way intended. Are they now?
Do you mind if I give way to my colleague Marina, who...
Thank you. So, in terms of the medical examiners, they cannot conduct their full role as medical examiners in the UK because we don't have the statute yet, but we're still doing the work. The level 1 is done by the doctors, but the level 2, we've set up the mortality group, which is great because we didn't have one before, so then we can now allocate the doctors in the group to do the level 2.
So when do we see a number of level 2s done on the dashboard?
Hopefully, because we have a monthly mortality group, hopefully in the next quarter we will be able to see something real and meaningful. But we update it every month when we have the mortality. The group only really got together about 2 months ago, so we need more people, and this is why it's important right across all the different care groups that people are identified who will lead on mortality, and they become part of the mortality group so that we have sufficient independence for the level 2 examinations.
Thank you, Marina.
Thank you. And the other one is complaints. You're showing 100% of complaints responded to in 20 days. Is that a first go at resolution, or is that a holding operation saying, thank you very much, we're sorry we've not got back to you about your complaint, and it's going to this committee, that committee, the other committee, and we'll be in touch with you again in another 20 days?
No, the vast majority of those are complaints that have been concluded. There are some that will be holding statements while we gather more information.
So they're not captured as to, right, so they're classed as been dealt with within 20 days, within
the timescales in the dashboard, yeah.
Right, so those are right, okay. All right, thank you. That's all.
Any other questions? No? Okay, thank you very much indeed. Our next board meeting held in public will be on the 31st of October. Costumes optional. Thank you. It's Halloween, you know. Who knows? Thank you very much indeed.
I should bring my cauldrons.